The subcommittee will come to order. The chairman will recognize himself for an opening statement. Today's Health Subcommittee hearing will examine the legislation authored by our colleague, Representative Tim Murphy, H.R. 2646, which is designed to help families struggling with crisis caused by mental health disorders. The bill makes available much-needed psychiatric, psychological, and supportive services for individuals with mental illness and families in crisis. With more than 11 million Americans who suffer with severe mental illness such as schizophrenia, bipolar disorder, and major depression, many are going without treatment, and often families struggle to find appropriate care for their loved ones. Since there is a patchwork of different programs and sometimes ineffective policies across numerous agencies, it is important for this committee to examine ways to fix the broken mental health system by focusing and coordinating programs and resources on psychiatric care for patients and families most in need of services. Over the past several years, Dr. Murphy, a practicing psychologist, has worked diligently to discern the most effective ways to research and treat these illnesses. As chairman of the Subcommittee on Oversight and Investigations, Chairman Murphy launched a review of the country's mental health system beginning in January of 2013. The investigation, which included public forums, hearings with expert witnesses, document and budget reviews, and GAO studies, revealed that the federal government's approach to mental health is a chaotic patchwork of antiquated programs and ineffective policies spread across numerous agencies with little to no coordination. The Helping Families in Mental Health Crisis Act of 2015, H.R. 2646, aims to fix the nation's broken mental health systems by refocusing programs, reforming grants, and removing barriers to care. I'm pleased we're holding this hearing today to hear from our witnesses and colleagues about their views on this pending legislation. I look forward to the testimony from each of you today, and I yield the balance of my time to Dr. Murphy from Pennsylvania.
Thank you, Mr. Chairman. Thank you for holding this hearing. Our mental health system is broken, badly broken. It's getting worse, and it has to be fixed. Same goes for our handling of substance abuse in this country. 40,000 suicide deaths in this country last year, 42,000 drug overdose deaths, 60 million with a diagnosable mental illness, 10 million with serious mental illness like schizophrenia, bipolar, or severe depression, 100,000 new cases a year. The General Accounting Office reviewed this for the committee, said we spend in the federal government $130 billion a year over some 112 programs and agencies that don't work together, have little accountability, and in many cases don't have very good results. I ask every member of the committee during this hearing and as we work forward on this bill to stop and think. Imagine you have a child who is hallucinating, schizophrenic, out on the streets, and you're told that the law says you have no right to know anything about your child's location, condition, or care. Others presume that having any information is harmful to your own child. Or if your child is brought before a judge with concerns for the symptoms and inability to care for himself, and the judge says it's not against the law to be crazy. I ask you to stop and think about that. Are we so lacking in compassion, and are we so ignorant of what serious mental illness is? Would we say it's not illegal to have a heart attack and walk away from the person with chest pains? Or how about dealing with someone with Alzheimer's? Would we say it's not illegal to have Alzheimer's and wander the streets in winter barefoot? Look, here's the truth. Serious mental illness is a brain disorder, and we must come to terms with this critically important fact, or else nothing else we do or say today will make any sense to anyone. Let me say this again. Mental illness, especially serious mental illness, is a brain disorder, and as such, has to be seen and treated for what it is. To believe otherwise is folly, anti-science, and an injustice to the person, denies them appropriate treatment, and sentences them to more imprisonment, homelessness, victimization, unemployment, and barriers to care. So I urge members to embrace this bill, and I thank all those members on both sides of the aisle who've worked with us and the many agencies and organizations who've done this as well. This bill is comprehensive. It's a first step, a big first step, but it does not fix everything. I wish there was a way we could go even further to build even more comprehensive changes, especially in dealing with substance abuse disorders. But this bill makes substantive changes in that, so those issues will be addressed. It sets the stage for more reform. I look forward to hearing from the witnesses, but I especially want to thank our witnesses today and Senator Creed Eads and others who are coming out to tell your courageous stories. I thank Chairman Upton for helping to schedule this hearing and move this forward. Let's make sure we provide more help for folks so we understand where there is help, there is hope. I yield back.
Chair thanks, gentlemen. And now pleased to recognize the ranking member of the subcommittee, Mr. Green of Texas, for his opening statement, also to help welcome one of our former colleagues here.
Thank you, Mr. Chairman, for holding this hearing on mental health reform. I'd like to recognize our former colleague, Patrick Kennedy. Good to see you. And thank you for your service and, of course, your family. And we keep it in the family. We have a relative on the committee. The Affordable Care Act made important changes in the field of mental and behavioral health. The landmark law expanded access to mental and behavioral health services, advanced parity of coverage, and enabled states to expand their Medicaid programs so that millions of more Americans could access affordable quality coverage. While the ACA made great strides toward improving access to mental and behavioral health services, the mental health system is still in need of reform. In our efforts to advance reform, it's critical that the patient remain at the center of our focus. Approximately 10 million Americans suffer from serious mental health illnesses, including major depression, schizophrenia, bipolar disorder, post-traumatic stress syndrome. The National Alliance on Mental Illness reports that between 70 and 90% of individuals have significant reduction of symptoms and improved quality of life with appropriate treatment and support. The numbers show that treatment works. Even though the overwhelming majority of individuals with mental and substance use disorders improved after receiving treatment, almost half of all adults living with serious mental illness do not receive treatment in the past year. Given that the statistics show that treatment's effective and that a considerable number of adults still go without treatment, our efforts to improve mental health care system must empower patients and their caregivers with access to a range of treatment and support services. We must also remove barriers to that access. In today's hearing, we're considering several pieces of legislation that seek to reform and improve our mental health care system. They are H.R. 2646, the Helping Families and Mental Crisis Act, and H.R. 2690, the Including Families and Mental Health Recovery Act. I appreciate my colleague from Pennsylvania, Dr. Murphy's endeavor to advance comprehensive mental health reform, and I particularly appreciate his relationship when we've been working on this for a few years, including during the Affordable Care Act. I do have some concerns about the legislation that may not adequately take into account the diversity and complexity of mental health needs that patients and their caregivers present. Comprehensive mental health reform must feature community-centered options that focus on recovery and prevention. We must ensure that reforms are patient-centered and address the full continuum of care. I look forward to hearing today more about this legislative proposal, and I also appreciate my colleague from California, Congresswoman Matsui, for efforts to improve mental health care delivery in the Including Families and Mental Health Recovery Act. The legislation seeks to improve the understanding of providers, patients, and caregivers on how HIPAA requirements apply to the mental health space. It will clarify HIPAA privacy standards for the release of protected information to patients, families, and caregivers, and increase education on this critical issue. I'd also like to thank our witnesses here today, and I look forward to their perspectives. With that, I'd like to yield 1 minute to my colleague, Congressman Kennedy from Massachusetts.
Thank the ranking member and thank the committee for holding this important hearing. To all of the witnesses, thank you very, very much for your testimony. I look forward to your insights. There's a familiar face, as I think everybody recognizes. Patrick, it is wonderful to see you here. I think you'll probably hear from your colleagues it's like you've never left. And if that's true, because it actually really is true, I get at least once a day people come up to me and say, Patrick, it's great to see you again. I get introduced often on the House floor as the gentleman from Rhode Island. I get often many of your colleagues relate to me how grateful they am for my leadership on these issues as they thank me, Patrick, for all that I have done, which of course you can imagine I say, you're very welcome, and take all of the credit for myself. And every now and again I let you know that, but often I don't. But Patrick, it is largely to your efforts in Congress that mental health parity is much closer to becoming a reality today than it was a decade ago. And that the Affordable Care Act has allowed 16.4 million previously uninsured people get the coverage that they need. But I think everyone here would agree that we still have a lot more work to do. A lack of access to care has had a heartbreaking consequence across our country. Just recently, I saw a report that stated over half of youth battling severe mental illness receive absolutely no help at all. Allowing so many children to fall through the gaps in our system leads to substance abuse and addiction, crime, and violence. In Massachusetts, as you know, we are in the midst of an opioid abuse epidemic that cost over 1,000 lives last year alone. Lives of rich and poor, young and old, male and female, black and white. Taunton, a city in my district, we've already tragically seen 10 people die just this year. It has been 7 years since the Paul Wellstone Act was signed into law by President Bush, and another year since those final rules went into effect. Lives cut short in every corner of our country serve as a stark reminder that true parity cannot wait another day. I look forward to hearing from each of our witnesses today about how the bills we're considering and other legislation can help ensure that loved ones battling mental illness and addiction not only have the access to care that they need, but that they can get those services without additional barriers. Patrick, thank you. I yield back.
Mr. Chairman, whatever time I have left, which is nothing, I'd like to yield to my colleague from New York, Congressman Tonko.
Sorry.
Recognized for 30 seconds.
I thank Representative Green and the chair for the opportunity. I'm pleased we're holding this hearing on such an important topic, and I wanted to take a moment at the outset to acknowledge and welcome my constituent and my friend, Mr. Harvey Rosenthal, to the panel. Harvey and I have known each other for many years and have long worked together to better the lives of individuals dealing with mental health challenges, most notably with the passage of Timothy's Law, which brought mental health parity to New York State before even our federal parity protections, which are outstanding. As the executive director of the New York Association for Psychiatric Rehabilitation Services, Harvey's passion and advocacy for individuals struggling with mental illness for over 40 years is unparalleled. So welcome, Harvey. Welcome, panelists. I greatly look forward to hearing your testimony today. And with that, I yield back the balance of my time.
Chair, thanks, gentlemen. Now recognize the chairman of the full committee, Mr. Upton, 5 minutes for opening statement.
Thank you, Mr. Chairman. There's no question that mental illness affects millions of Americans and their families. Yet, sadly, way too many are going without treatment, and their families are certainly struggling to find care for loved ones. Following the tragic events of Newtown, Connecticut, this committee led a multi-year review of the federal mental health system. Ensuring treatments and resources are available and effectively used for those suffering with mental illnesses has remained a real priority of this committee throughout the past number of years. I particularly commend Oversight Investigation Subcommittee Chair Tim Murphy, who has led and spearheaded our thorough review of all federal mental health programs. This committee held a series of public forums, briefings, investigative hearings to determine how federal dollars are being prioritized and spent on research and treatment, particularly for serious mental illness. To address the flaws discovered in the extensive wide-ranging examination, Chairman Murphy introduced H.R. 3717, the Helping Families in Mental Health Crisis Act of 2013. And 2 major pieces of that bill became law in the last Congress, and today we continue our efforts to look upon building on that success. Dr. Murphy has reintroduced this bill in this Congress, building upon the previous bipartisan version while updating it to include new findings from the committee's continuing investigation. H.R. 2646, this year's bill, would remove federal barriers to care, clarify privacy standards for families and caregivers, reform outdated federal programs, expand parity, accountability, invest in services for those with serious mental illness, and provide and promote evidence-based care. Every community, every single one, has been impacted in some fashion, and literally every family as well. To our community leaders on the front lines in my district, folks like Jeff Patton, who runs the Kalamazoo Community Mental Health and Substance Abuse Services, we say thank you. And to those families who have been impacted by mental illness in some form, Congress is aware, yes we are, of your plight, and we can, and we must, and we will do much better. I want to thank our witnesses for taking the time to testify before the subcommittee, particularly my friend, former colleague Patrick Kennedy, Virginia State Senator Creigh Deeds. We have an all-star panel, that is for certain. And I yield the balance of my time to the Vice Chair of the subcommittee, Ms. Blackburn.
Thank you, Mr. Chairman. And to our witnesses, we do thank you so much for being here. We are deeply appreciative of the time, and we know Congressman Kennedy has had this as an issue close to his heart for a long time. So we appreciate that you're here to share. I think that Tim Murphy deserves a tremendous amount of credit for the work that he has put into working through this process for the past couple of years. You've got 10 million Americans that are in need of services and who suffer some form of mental illness, severe mental illness. The federal government is spending $130 billion a year, and people are not getting the services that we need. And in our district, Centerstone is a group that we have worked with on these issues for a period of time. And we were looking at the homeless population, some of the figures related there, and the fact that so many of these individuals end up in our jails. And this is something that needs to be addressed. They are sick and they need care. And in Tennessee, there were a total of 21,246 inmates in fiscal year 13. Of those, 11% were diagnosed with a severe mental illness. Another 21% were diagnosed with nonspecific mental illness, and 16% were prescribed at least one psychotropic medication. But see, we've got this gap on outcomes and what the deliverable would be. And we are so grateful to Chairman Murphy's leadership for helping us hone in on this to make certain that needs are addressed, that there is a process for care delivery, and there is a process for these individuals to have a quality of life. And so we're going to have questions for all of you today, and we thank you for your commitment and for your time. And Mr. Chairman, I yield back.
Chair thanks the gentlelady. Now recognizes the ranking member of the full committee, Mr. Pallone, 5 minutes for opening statement.
Thank you, Mr. Chairman. I know that Patrick Kennedy, our colleague, has gotten all kinds of accolades, but I want to add to it because, you know, I think many of you know, or maybe you don't, that, you know, he was dealing and urging us to pass a mental health parity bill long before we even had it included in the ACA, and then he advocated when we were passing the ACA to expand it, which is exactly what happened. And I also would mention that he's not only an advocate domestically, but also internationally. I remember when you and I went to Armenia together, and you went there because of the Special Olympics and trying to set up the Special Olympics in Armenia. So thanks for all that you do, Patrick, and it's good to see you. Today's hearing gives us the opportunity to discuss an important public health issue. According to the National Alliance on Mental Illness, approximately 1 in 5 adults in the U.S., or 43.7 million, will experience mental illness in a given year. Of those people, approximately 10 million live with a serious mental illness, including major depression, schizophrenia, and bipolar disorder. We've taken significant steps forward in recent years. The Affordable Care Act's passage was quite literally the largest expansion of mental health and substance abuse disorder coverage in a generation. The ACA prohibits individuals from being denied coverage due to a pre-existing mental health condition. It expands eligibility for Medicaid coverage and requires most health plans, including Medicaid, to cover mental health and substance abuse services. Not only are services covered, but mental health parity now applies, protecting 62 million more Americans. This means that no insurer can impose requirements that are more burdensome for mental health than they can for physical health. Despite these major advances, far too many individuals still go without the treatment they need to live long, healthy, and productive lives, and more must be done to ensure coverage translates into effective treatments and actually meets parity standards. That's why I'm interested in hearing from stakeholders on what is working, what is not working, before we move forward with extensive or comprehensive legislation. For instance, Parachute NYC is here to discuss their innovative new approach for respite care for the seriously mentally ill, and I believe we can learn valuable lessons from this project and others funded through the ACA. Mr. Chairman, unfortunately, like last Congress, the first Health Subcommittee hearing on mental health is once again a legislative hearing on the Helping Families and Mental Health Crisis Act. As a result, the subcommittee will focus on solutions as framed by this bill instead of being framed by the needs of individuals with mental illness and the system that serves them. While I have concerns with this process, I want to recognize that there are provisions of H.R. 2646 that I strongly support, including the increased focus on workforce development and the parity enforcement reporting requirements. However, I am opposed to several provisions in the bill, including its changes to HIPAA that would weaken the privacy rights of individuals with diagnosed mental illness, the conditioning of community mental health block grant funding on the presence of state AOT laws or treatment standard laws, and cuts in funding to substance abuse programs to pay for new mental health programs. As we all know, too often substance abuse and mental health go hand in hand, and we have a crisis in both areas. So I hope that after this hearing we can work together and find common ground to move bipartisan legislation forward that further advances the mental health system in this country. I'd like to yield the remainder of my time to Representative Matsui.
Thank you, Ranking Member, and I welcome all you panelists, and nice to see you, Patrick. All of us know that we need to reform our nation's broken mental health system, and we should all care about this issue before, during, and after a crisis or an event that affects us personally. We shouldn't wait until a person is in acute crisis to provide needed care and services, and we shouldn't abandon people once their immediate crisis has ended. There is a full spectrum of mental health and illness that our system needs to address, and a full spectrum of treatment, options, tools, and services, and supports that we need to make available. We should not prioritize funding only for the highest level of care, such as inpatient hospital beds, at the expense of funding the rest of the continuum of care. I believe in the power of prevention, and that we need to do more to catch many conditions, including mental illnesses, early before they progress. I know our current system is flawed, and I look forward to working with my colleagues to fix it. That is why I introduced the Including Families in Mental Health Recovery Act, which is one of the pieces of legislation that we're discussing today. Stories of patients and their families who suffer from mental illness do affect me personally, time and time again, including what will be in testimonies today. I've heard horror stories from patients, families, and providers about what happened when providers could not communicate with caregivers and information wasn't shared. I hear from providers and families alike and the mantra, I couldn't share because of HIPAA. However, the language of the HIPAA law does not prevent information sharing in 99% of the stories I hear. Rather, it is a vast misunderstanding, misinterpretation, and overly cautious application of the HIPAA law. This is important. There is a problem here, but HIPAA isn't the root cause of it, which means that changing HIPAA won't fix anything. The root problem is awareness of what is and isn't allowed under the law. The bill that I introduced would do two simple things. First, formalize HHS Office of Civil Rights Guidance, which clearly outlines how providers can strike the right balance between sharing information with caregivers and protecting patients' privacy. Second, it required the development and dissemination of a model training program to educate and train providers, administrators, and lawyers, and patients and families on what can and can't be shared under the law. I appreciate this hearing. I look forward to working with all of you. Thank you, and I yield back.
Chair, thanks to the gentlelady. That concludes the opening statements of the members. As usual, the written opening statements of the members will be entered into the record. We'll now go to our panel, and I'll introduce them in the order of their presentations. First of all, the Honorable Craig Deeds, Senator of Virginia, welcome. And then our former colleague, the Honorable Patrick Kennedy, former U.S. Congressman from Rhode Island, founder of the Kennedy Forum. Jeffrey Lieberman, MD, Chairman, Department of Psychiatry, Columbia University College of Physicians and Surgeons, welcome. Mr. Paul Gianfrido, President and CEO of Mental Health America. Steve Coe, Chief Executive Officer of Community Access. Ms. Mary Jean Billingsley, Parent, National Disability Rights Network. And Harvey Rosenthal, Executive Director, New York Association of Psychiatric Rehabilitation Services. Thank you all for coming today on testifying on this very, very important subject, and your written testimony will be made part of the record. You'll each be given 5 minutes to summarize your testimony. So the chair at this point will recognize Senator Deeds, 5 minutes for your summary.
Thank you, Mr. Chair. Thank you, members of the committee, for giving me a couple of minutes. Thank you, Congressman Murphy, for making mental health issues, bringing them to the forefront, helping to develop solutions to help families in crisis throughout the country. When formulating my thoughts about what I wanted to speak about today, how best to use my time, I thought about all the compelling stories that have been shared with me from Virginians and from people all throughout the United States. Honestly, I thought, what could be more compelling than the loss of those innocent lives in Newtown, the moviegoers in Aurora, the bright emerging leaders at Virginia Tech, or the dedicated public servants at Navy Yard? In Virginia, we tinkered around the edges of public policy following tragedy, but the real reform and meaningful work remains. But if we did not act after all those unspeakable tragedies, what could I possibly say today to you to press upon you the importance of acting? The importance of coming together and finding solutions, many of which are here before you in H.R. 2646. In addition to each of those high-profile cases involving large losses of life, there are tragedies of smaller scales. You can read about Nastasia, a woman with mental illness who ends up in jail instead of a mental health treatment facility that can properly care for someone with an illness. When the jail attempts to transfer her, 6 members of law enforcement in biohazard suits handcuff, shackle, and place a face guard on her. When she refuses to bend her knees and sit in a transport chair, she's tased multiple times. She dies. If she was in a mental health facility and needed to be sedated, the staff would have had appropriate options. I can only imagine what she was thinking and feeling when all those men entered her cell in spacesuits. And I can only imagine how much grief and pain her family is enduring today. You can read about Christian, a 17-year-old boy with a knife threatening suicide. Law enforcement was called to the scene, and when the boy made movements toward the officer, he was shot dead. I can only imagine the shock and horror of his friend who had called for help. Tragedies happen every day that involve someone in a mental health crisis. Most do not make the news. I've heard so many, and those stories serve to guide me in my review of the mental health system in Virginia. The heartbreak is unbearable. I hear those stories, I hear them every day. People reach out to me for help every day, and the sad truth is that in many ways, there's little I can do to help. The system is not set up in a way that encourages advocacy. One of the primary issues I see is HIPAA. We came together in a bipartisan way in Virginia to adopt meaningful reforms last year and to some extent during the 2015 session. But nothing we can do can circumvent HIPAA. The states need the federal government as a partner in reforming the mental health system. Government was not envisioned to work quickly, and we are geared toward incremental policy changes. But I'm telling you, the time for action is now. Families are struggling, people are dying, people are grieving. While there is no panacea, there are things to be done to improve the lives of people with mental illness, promote better outcomes, and to help give relief to families who are struggling every day. We can accomplish this without jeopardizing the civil liberties of those with mental illness. While I do not like to speak about my own situation, I want to end briefly talking about Gus. No legislative action here in the District of Columbia nor in Virginia will bring back my son, but hopefully it will help others keep their loved ones safe. I have 4 precious children. My 3 daughters make me prouder every day, but I have forever lost my son. I worked within the mental health system to help Gus when he began to show signs of mental illness. He was brilliant. Everyone in this room would envy his adeptness at picking up language, his knowledge of religion, his ability to play any instrument he'd pick up, and his kindness and gentleness to his fellow man. My world was shaken to its core when he began showing signs of delusional thinking and sporadic behavior. I was just not equipped with the knowledge or the information to help him. HIPAA prevented me from accessing the information I needed to keep him safe and help him toward recovery. Even though I was the one who cared for him, I was the one who fed him and housed him, transported him, insured him, I was not privy to any information that would clarify for me his behaviors, his treatment plan, his symptoms, to be vigilant. I had no idea. I didn't know his diagnosis, his prescription changes, and necessary follow-up. I'd sought to have him hospitalized earlier, so he was the best information I had. The last time I tried to hospitalize him, he was turned away. We ran out of time and law enforcement had to release him. We have to do better. Not for me, not for the countless other families who've already buried their loved ones, but for those who struggle with mental illness and the families that struggle to help them. They're crying out for help, they're desperate, they're exhausted, and they need your leadership. Thank you.
Chair, thanks, gentlemen. Patrick, you're recognized 5 minutes for your opening statement.
Thank you, Mr. Chairman. First, I think I speak for all of us, Senator Deeds, when we say our hearts go out to you. I don't think there's a person in this country that wasn't moved by your tragedy and what it speaks to all of us. All those tragedies go by, and as a nation have failed to act is abominable. And I think what you said is what we all need to hear over and over again. The time is now. And Representative Murphy, thank you for stepping up. I know you've drawn a lot of criticism and this bill is imperfect, but you've had the fortitude to stick with it and to keep pressing. And you've listened to people and you've shaped legislation that moves us forward. Is it the answer? As you rightly said, no, it's just a piece of the answer. But as you said at the very start of your remarks, the essential message we need to come out of this hearing is that these are real physical illnesses and they need to be treated with the same urgency that we would treat cancer or any other fatal or disability in this country. The notion that we treat these issues as moral issues as opposed to medical issues is really the central issue before this committee. And I'm honored to have been honored to work with many of you to get the Mental Health Parity and Addiction Equity Act passed. And that bill, if implemented, and I've heard comments already from many of you, including my cousin Joe, will transform the system, because if the liability is on payers, including the federal government, to treat brain illnesses like any other illness, then they will start to see that an ounce of prevention is worth a pound of cure. That investing in early identification and treatment and intervention is the answer. Just like with cancer, just like with diabetes, just like with cardiovascular disease. We don't wait till these illnesses become pathologized before we treat them. But with mental illness and addiction, what do? We wait until you're in crisis before our system ever starts to kick in. And then people blame the system as not working because somehow it doesn't take someone with stage 4 cancer and make them well. Are you kidding me? If we don't intervene early, these illnesses do become intractable. But we don't have to let it be that way. We can intervene early. We can save lives. But the basic premise to all this is just treat these like you would someone with cancer and not wait around until the illness gets to become worse and in a crisis stage. So, Representative Murphy, I'm sure we'll have a chance to talk in great length about the details of this bill, but I just want to salute you for putting forth a number of issues that we can talk about and we can begin to explore as ways to improve the system. The system needs accountability. The system needs transparency. And you have been a champion of those things, and I think that they are throughout your legislation, and it's why I'm honored to be here to work with you and my Democratic colleagues to make sure that this House passes something to answer what Senator Deeds put forward to us, and that is to act and to act now. Thank you.
Chair, thanks, gentlemen. Thank you for your leadership and your passion. Dr. Lieberman, you're recognized 5 minutes for your opening statement.
Thank you, Chairman. Thank you, Chairman Pitts. Ranking Members Green and Pallone and honorable committee members, I'm pleased to be here attending this hearing. I also would like to thank Representatives Murphy and Johnson for their enlightened legislation and express my gratitude to Representatives Upton and DeGette for the critical leadership on the 21st century cures. I'm professor and chair of psychiatry at Columbia University and psychiatrist-in-chief at New York Presbyterian Hospital, and have spent my career doing research on the neurobiology and psychopharmacology of psychotic disorders. In addition, I've, throughout my career, taken care of patients, both overseeing clinics with trainees as well as having patients that are directly in my own practice. I am a member of the National Academy of Sciences, Institute of Medicine, and the past president of the American Psychiatric Association. I mention this simply to say that I believe that I'm in an informed perspective to express knowledgeable opinions about the field of mental illness and mental health care. And in the course of my career, I can say that I have continuously borne witness to all that Senator Deeds and Congressman Kennedy have described to you. The stories are countless, innumerable, and appalling. But in the time I have, I'd like to make 3 points. First, that psychiatry is a scientifically based profession, no different from cardiology, neurology, or ophthalmology, although in deference to, to Representatives Burgess and Bouchon, maybe not as advanced as obstetrics and gynecology and cardiac surgery. But the second is that although we have an egregious chronic crisis in mental health care, this is solvable. You deal with a lot of problems that are not solvable. Alzheimer's disease in the aging population, global warming, terrorism. This is a solvable problem. And the third is I want to describe what providing quality and comprehensive mental health care will do for our country. When I was a medical student in third year in the mid-1970s at George Washington University, I told my advisor that I wanted to go into psychiatry. He exploded and says, "What would you do a dumb thing like that for and throw away a perfectly good career?" Psychiatry was then and still is the Rodney Dangerfield of medicine. It doesn't get the respect it deserves. But that's because for the first 150 years of its existence, psychiatry had little to show for itself. No scientific information of mental illness, and no effective treatments. It could do little to help people with mental illness other than to institutionalize them, and those became appalling snake pits. But that was then and now is now, and everything has changed since the scientific revolution of the latter 20th century, beginning with the arrival of psychotropic drugs. And as a result, psychiatry has a strong scientific foundation and an array of evidence-based treatments that are effective and safe. What this means is that we have the knowledge and the means to solve this crisis. To do this, though, we have to provide a template of comprehensive evidence-based services to health providers at the state, county, and municipal levels, and align financing mechanisms to incentivize providers to adopt these. In addition, and this is something that is not widely appreciated, we must dispel the stigma of mental illness, just like we have in our society for other things, such as racism, sexism, anti-Semitism. There still is prejudice against mental illness in psychiatry due to its inglorious past. But these anachronistic attitudes confuse people, create fear and mistrust of mental health care, and deter people from seeking and getting help. The Helping Families in Mental Health Crisis Act offers a transformative opportunity. If we're successful, and we can be, we will lessen the burden of illness and improve the quality of life of our citizens, and also alleviate some of the most disturbing and dispiriting problems in our society, including domestic violence, addiction, suicide, the mentally ill who are homeless and increasingly in prisons, the shocking rates of PTSD and suicide in military personnel, and the recurrent episodes of these civilian massacres and mass violence perpetrated by some people with untreated mental illness. And as a bonus, comprehensive, effective mental health care would also deter the massive inflation in health care costs driven by patients with comorbid mental disorders who receive repeated and unnecessary medical and surgical services. One final comment is that it's imperative that in the process of revamping our mental health care system that we be guided by scientific evidence and not ideology or opinion. Science guides cardiovascular medicine, oncology, orthopedics, neurology. It should guide mental health care as well. The 21st Century Cures, I hope, will address an egregious chronic underfunding of the biomedical research community, because ultimately research is what drives the quality of care. We have the means to solve this crisis, We simply need to find the social and political will. I thank you for having me, and I await your comments and questions.
Chair thanks, gentlemen. Now recognize Mr. Gianfrido, 5 minutes for opening statement.
Thank you. I want to applaud this subcommittee, and in particular Congressman Tim Murphy and Congresswoman Eddie Bernice Johnson for your leadership in this area. As a parent of an adult son with schizophrenia, I deeply appreciate this because for so many of us, this is not just a policy matter. This is our life. As a former state legislator in Connecticut, I know how difficult it can be to build consensus around mental health policy. I therefore also appreciate the effort of the sponsors to invite so much feedback during the past year and to use it to shape the proposal before you today. In our view, H.R. 2646 is an important start to making comprehensive mental health reform a reality in America. In these brief remarks, let me focus on some areas that are important to MHA. Its emphasis on moving upstream in the process, that is, on intervening before stage 4, is a critical step forward to treating mental illnesses like we treat every other chronic disease. It includes funds for screening, early intervention, and treatment programs. And let me share why this is so important. In the spring of 2014, MHA launched an online screening tools through our website at mhascreening.org. To date, nearly 500,000 screens have been completed, nearly half by people under the age of 25. 2/3 screen as positive or moderate to severe for the condition for which they've screened, but 2/3 of those say they've never been diagnosed with a mental health condition. Screening is the doorway to services and treatment. H.R. 2646 makes screening, especially for children and young adults, a part of the innovation grants, the demonstration grants, the youth suicide prevention program, the campus mental health program, among others. And in legislation that emphasizes building on evidence-based programs, we note the importance of innovation, because today's evidence-based program is yesterday's well-evaluated innovation. In addition, it is our hope that we'll look to expand the opportunities to integrate health and educational services for our children. My son Tim has schizophrenia. He's 30 years old today, living mostly on the streets of San Francisco. He first showed signs of the disease when he was a young child. Throughout his school years, we sought special education services for him and were frequently rebuffed. This is because those of us making policy a generation ago were not thinking about children like Tim as we implemented our modern special education laws. Today, only 362,000 children in the country receive special education services because of an SED label. That represents only 1 child in every 28 NIMH says has a serious mental health condition or concern. This represents too many tragedies waiting to happen. MHA endorses the empowerment and elevation of the lead federal agency in this legislation, and we hope you'll consider adding 2 additional responsibilities to it. The first would be to establish a common standard, other than danger to self or others, as a trigger to involuntary treatment for SSI, because this is not a clinical standard. The second would be to develop a national plan that would result in an end to the incarceration of nonviolent people with serious mental illnesses. We also endorse the efforts to enhance the mental health workforce in this bill. At MHA, we have a special interest in the peer workforce. And in this legislation, we see an opportunity to develop a properly credentialed peer workforce that could work competitively at competitive salaries in clinical settings. With respect to AOT, we support the approach in this legislation that it takes not to mandate it nationwide. We encourage the committee's review of language that may appear to be in conflict with the intent of the sponsors and revise it if need be. And we also support changes to the privacy rules, because the current rules are an impediment to integrating health and behavioral health care. You can't fully integrate care with only half a medical record. But as someone who has worked closely in the past in Austin, Texas, with community-based providers seeking to integrate care, I worry that meeting simultaneously the 6 conditions may be so difficult and time-consuming for providers that many will not try. Consider as an alternative this: clarify the relevant law to eliminate the superauthorization needed to share behavioral health information. This will promote integration without compromising an individual's right to manage the release of his or her protected health information. Finally, we understand the need to offset new expenditures with reductions in other areas, but worry that the offsets might come from existing community health programs. If you want to find offsets, please look to our jails and prisons. By sending so many of our children, like my son Tim, to those 21st century asylums, that's where we sent the funding we need for mental health services today. In closing, for more than a century, MHA has argued, for more than a century, that it's well past time to address mental health issues in a comprehensive, thoughtful way, and this is a start. Let's work together to remove the stigma associated with seeking help for mental health concerns and the discrimination that occurs against those who live with them. Let's put in place a mental health system that allows us all to move upstream, provide the behavioral health services individuals need and deserve early, and enforce parity and coverage. Let us address mental health concerns before stage 4. Thank you.
Chair thanks, gentlemen. Now recognizes Mr. Coe, 5 minutes for your opening statement.
Chairman Pitts, Congressman Murphy, thank you very much for inviting me to come today. It's very important legislation, and I congratulate you for your vision. As you can see from my resume, I've worked as a CEO at the same agency, Community Access, for almost 36 years. I like to tell people I may have worked here a long time, but I've had the same job for only one day. For instance, I wasn't testifying before Congress yesterday. Next week, I'll be at a conference in Norway learning about assertive community outreach programs in Europe. And with hundreds of employees and 1,100 tenants and 20 apartment buildings from the Bronx, Manhattan, and Brooklyn, something different is happening every day. Most of what happens at Community Access is inspiring, which is another reason I've worked here so long. As my submitted testimony describes, our organization was founded by family members, led by the brother of a woman who had spent years confined to psychiatric hospitals and then more years cycling between squalid housing and more hospital wards. His name was Fred Hartman. Fred inspired me when I met him as a graduate student studying housing and service models that would break the revolving door cycle common in the 1970s when states discharged thousands of patients into our communities without proper supports. Fred's day job was editor of Natural History magazine, but he was really an activist and an organizer. As a white New York City kid, he got on a bus and went to help black Americans vote in the South. When faced with the human misery and injustice experienced by his own sister, he recruited friends and colleagues and created a better mousetrap, an improved model of care that would give former patients a safe, stable, affordable home and basic supports. Community Access started out renting apartments in rundown tenement buildings. Today, we build modern apartment buildings with amenities like free Wi-Fi, 24/7 front desk service. But the core elements remain the same. People choose their own apartments and who they want to live with. They sign leases, they're responsible for their own bills, and our buildings integrate affordable housing for families and children with units for formerly homeless people recovering from mental illness, referred directly from the New York City shelter system. We even have a subsidy program to encourage pet ownership. Overall, I feel H.R. 2646 supports many of the principles we embrace, an emphasis on results and outcomes, recognizing the valuable role peers can play in the workforce, support for innovation and demonstration projects to test new ideas, and more. But while there is a lot to like in H.R. 2646, the principal vehicle offered to achieve these results, AOT, is not what Fred would do. He believed too strongly in human rights and social justice, passions that I share. We can all agree our system of care fails on many fronts, and nowhere more than in the provision of crisis services and supports. H.R. 26 acknowledges this fact within the title of the bill to make supportive services available to individuals and families in mental health crisis. H.R. 2646 doesn't spell out what these supports should look like, which makes potential supporters of reform legislation, like myself, extremely wary. AOT is not a defined service. It can mean anything, and not much at all. In New York City, for instance, an AOT-assigned individual is given priority access to supportive housing, which research shows is the most effective tool in promoting community stability and is entirely absent in many places. What service is going to take its place if this person in crisis is homeless? A higher dosage of medication, a 15-minute visit to a psychiatrist, a hospital bed? Without standards, AOT can mean anything, including interventions that have no evidence base whatsoever. If we want true reform, let's mandate specific interventions that we know work, and many of which are mentioned in H.R. 2646. Mobile crisis teams, crisis intervention training for first responders. Only 3,000 of the nation's 18,000 police departments use this common sense approach. Patient-centered treatment planning, targeted case management, psychiatric rehabilitation services, which is evidence-based, peer support and counseling services. Adding a guaranteed housing subsidy, and there have been cutbacks continually in Section 8 at the federal level, 24/7 walk-in centers, peer-operated support lines, like we operate with the Parachute NYC program, and reform to the Ticket to Work program so it actually becomes a pathway to a job would truly transform the lives of millions of Americans with mental illness. States are already mandated to provide many services, including public education and prisons. How fervently they have chosen to embrace these mandates and fund them varies widely, and there is no reason to expect a vaguely defined mandate for an AOT program would turn out any better. Healthcare reform, with an emphasis on preventive services, integrated physical and mental health care, and crisis supports to avoid costly and traumatic hospital care, is already driving reform efforts across the country. H.R. 2646 should look to support what is already happening in the marketplace and not place another unfunded mandate on our state governments. Thank you.
Chair, thanks, gentlemen, and now recognize Ms. Billingsley, 5 minutes for an opening statement.
Good morning, Chairman Pitts, Ranking Member Green. Thank you for the opportunity to testify today on this important topic that has touched me and my family personally. My name is Mary Jean Billingsley. I have a master's degree in counseling and personnel services. But more importantly, I am the mother and co-guardian of Tim Costello. Tim is 22 years old and is duly diagnosed with both significant mental illness and developmental disabilities. Tim lives in Johnson County, Kansas. We are one of the families with a positive outcome that would not have been possible if the Helping Families and Mental Health Crisis Act of 2015 was law when my son encountered his problems. Several provisions of this legislation would have a detrimental impact on the work of the protection and advocacy for individuals with mental illness, the PAMI program, in addressing Tim's needs. The changes to the PAMI program in this bill would not help families, but would in fact harm families like ours. Tim's mental illness manifests itself with certain behaviors. Because of these behaviors, Tim was placed in a psychiatric institution in 2010. He was 17 at the time. In the summer of 2011, Tim was going to be discharged with no plan and without proper supports in place. Without those supports, Tim's discharge was doomed to fail. We were devastated. Because Tim has both significant mental illness and a developmental disability, the different providers were trying to pawn Tim off to each other. Tim was always somebody else's problem. Without the right supports, Tim was going to continue to cycle in and out of institutions at a high cost to both taxpayers and Tim's ability to recover. Tim wanted to live in the community. Our family wanted Tim to live in the community. This is a right granted under the Americans with Disabilities Act, allowing him to get needed treatment in the community instead of at an expensive psychiatric institution. We contacted the Disability Rights Center of Kansas, the federally mandated protection advocacy agency for people with disabilities, which operates the PAMI program. Because of the PAMI program, DRC was able to help Tim and my family with this complex situation. Sorry, I missed a page, excuse me. Every brick wall the system threw up against us, the PAMI program gave DRC the authority to tear it down. Kansas policy made it impossible for young adults like Tim to transfer out of psychiatric institutions to community long-term care programs with needed supports. DRC was able to negotiate a change in this policy, allowing Tim to obtain services through the Money Follows the Person program and obtain the long-needed supports in order to live successfully in the community. This bill would prohibit PAMI-funded programs from engaging in much-needed policy work, even using non-federal dollars. Tim's civil and human rights under the ADA would not have been protected. Tim was living successfully in the community, and we thought our problems were over, but they were only beginning. Tim then faced discrimination simply because of his disability. Some local governments in Johnson County, Kansas, started using zoning and land use ordinances to attempt to close Tim's community group home, as well as others. A not in my backyard attitude prevailed, targeted against Tim and others because some did not want those people living in their neighborhood. We again contacted DRC for help. After failed attempts to work with local governments, Tim and 16 other similar individuals with disabilities urged DRC to file disability discrimination complaints with Housing and Urban Development, alleging violations of federal and state laws. The HUD case is currently pending. If this bill were law, the PAMI program would have been prohibited from helping our son with legal advocacy in the housing discrimination case because it is not abuse and neglect. The current PAMI law has no such limitation. Without the help of DRC and the PAMI program, Tim would still be cycling in and out of institutions. The resolution of Tim's current discrimination case may require DRC to seek a change in policy through legislation or local ordinances, which they currently can do using non-federal funds. H.R. 2646 would prohibit this and severely limit the remedies available for Tim. Tim's case was complicated. The PAMI program gave DRC the ability to engage in every aspect of protecting Tim's rights, including the flexibility to use non-federal dollars to engage in needed policy change. Tim's prior institutionalization and current housing discrimination involves numerous disability rights issues, including unjust denial of Medicaid services, violation of rights under the ADA, and housing discrimination. Often the issues faced by people with mental illness are not abuse and neglect, but the problem of human and civil rights. In closing, this bill would limit the authority of the PAMI program to cases of abuse and neglect, making it far easier to discriminate against and violate the rights of people with mental illness. It would also eliminate advocacy for policy changes, even with non-federal dollars, on behalf of persons with disabilities, including mental illness. Those provisions are bad for families and bad for my son, Tim. Thank you for the opportunity to testify.
Chair thanks the gentlelady and now recognizes Mr. Rosenthal 5 minutes for his opening statement.
Good morning, and thank you for this extraordinary opportunity to testify today. I'm Harvey Rosenthal.
Is your mic on?
Yes.
Yeah, go ahead.
Thank you. Sorry about that. A person in 43 years of recovery from a bipolar disorder, with 40 years of experience working in the field, 18 in a hospital, clinic, and rehab program, and 22 working as an advocate, who has come to sit on New York's Medicaid redesign team, its behavioral health work group, and our most integrated setting council. Thank you for including a recovering person here. I urge you to include more of us in these deliberations. My experience has told me that the best way to fix a broken system isn't by forcing people into the exact same services that have failed them in the past. It won't be achieved by reducing privacy protections, limiting access to personal and systemic advocacy, or by all of a sudden moving sharply to a medical, biological bent in ways that could undo or jeopardize the extraordinary gains of the recovery and consumer-focused approaches that have taken us decades to develop. I want to, I am actually, we're not working on my comments. They will tell you in my written comments, they will explain my position. I woke up this morning and I felt like I had to use and focus on a word that has barely been discussed today, and that's recovery. And so, as I said before, recovery, rehabilitation, consumer, and peer support movements have changed the face of service delivery to people with the most serious mental health conditions in this country and around the world. Before these movements took hold, our system told people they would never get well, never have intimate relationships, never get a job, and never be able to make most of their most personal decisions. I know because I saw it every day when I worked in the state hospital. We told people they would never get a job, that they'd be poor, idle, isolated, and segregated from society. They would be permanently disabled. The primary treatments of the day were medication and hospitalization. And I know we're talking a lot about that here in the bill, but we're not talking enough about recovery. We're talking a lot about meds and beds, but not enough about recovery. Our movements brought hope to people and their families, many for the first times. Hope was and is still not enough a part of our toolkit. Even the sickest person can improve and get well, although they are dissuaded from going to services if the service message is that you're sick, that you need to take medication, that you can't make decisions, that you will face coercion, that your privacy rights will be violated. It's not a way to engage people. I will tell you a way to engage people. We run a Peer Bridger program in the streets of New York City. We work with the hardest to serve, people that are very sick and don't have good housing, who have addiction and trauma, and are by definition hard to find, victims of abuse, veterans. These are our greatest challenges. We developed a model of peer bridging that hits the streets. Too much of our system stays in the office and blames the patient. We hit the streets and we go again and again and again to engage people. We work with families. We have helped hundreds of people in the city reduce their reliance, reduce their relapses and their readmissions by 50%. Yet these services have not reached the standard of evidence-based practice. We must. We're talking about research on brains. We have to also do research on peer services and recovery services, because otherwise we'll undo them. When we talk about AOT, we're typically mandating people to take medicine in a hospital. When we talk about limiting what P&As do, we're talking, again, we're fearing that people will get off medications. When we're talking about the IMD exclusion, we're talking about more beds. We've come a long way to just talk about medications and beds. And, you know, when we talk about importing all of SAMHSA into the office of a new assistant secretary, we're gambling on the possibility that all of the work that has been done to transform and offer hope, recovery, wellness, employment, community integration, person-centered and self-directed care might get lost in a large bureaucracy. There are some out here that believe the recovery movement is the enemy, that we're not interested in working with the sickest individuals. But I can tell you that we have helped tens of thousands of people stay out of jails and prisons and homeless shelters and avoid suicide. I must absolutely be able to really focus on funding these programs. We greatly need to offer the promise of recovery to people. You'll see in my comments that we support a number of the things of Chairman Murphy. We laud him for his passion, but we really need to see a full range of recovery services like Steve has talked about. There's not enough focus here in the bill, and it has to be said. Thank you.
Chair thanks the gentleman, thanks all of our witnesses. That concludes the opening statements of our witnesses. We'll now begin questioning, and I'll recognize myself 5 minutes for that purpose. Dr. Lieberman, we'll start with you. Do you believe that the community mental health system developed in the 1960s was designed to serve the needs of individuals who experience the most chronic and severe manifestations of mental illness? And if not, what are the consequences of this?
Mr. Chairman, it may have been designed with that intent, but it was really woefully naive and ill-conceived, and it failed miserably. I mean, the idea was to humanize mental health care by being able to move patients from institutions into the community and have them receive an array of support services, including housing, including case management, including medication and rehabilitation, but none of that was there. And they simply fell through the cracks, and we've never sort of regained traction on that problem and that population since.
Mr. Gianfrido, how has the deinstitutionalization of the mentally ill worked out over the past half century? In your opinion, in your experience, why do so many mentally ill individuals pass through our criminal justice system or end up homeless? And are these individuals getting treatment while in prison or living on the streets?
Those of us who were policymakers in the 1970s and 80s really didn't understand two things about our system. One was that we were going to have to put front and center the kind of clinical services and support services that people would need when they were not in institutions. The second was we didn't understand that the pipeline was a pipeline of children, that these were illnesses that primarily affect initially children and young adults. And so as a result of that, what we've ended up doing with deinstitutionalization, the kind that we did in the 70s and 80s, was a reinstitutionalization of people into prisons. And those prisons and jails are not at all connected with the rest of the system, and that's a real tragedy.
Mr. Kennedy, at the present time, how does the IMD exclusion impact on the availability of clinically effective inpatient treatment options, particularly for Medicaid enrollees? How, if at all, would Title V of H.R. 2646 go about fixing that?
Well, first of all, we have to understand that if we're going to treat these illnesses like all other illnesses, if the illness is critical and needs intensive inpatient treatment, you wouldn't limit that if it were the cancer patient. You wouldn't limit that if it was the cardiovascular patient. And you shouldn't limit that simply because the patient is someone with a psychiatric disorder. So I understand the derivation of this IMD exclusion. It came out of the days when people were warehoused, where care was substandard and horrifying. And yet we took a polar opposite approach by just not paying for any inpatient treatment as a result. Now we've progressed 5 decades, and we're stuck in the same mentality as 5 decades ago? No, we should follow the science, treat these illnesses as real illnesses, and in doing so, treat them if they need to be treated in inpatient settings, do so, and not preclude that as an option.
Senator Deeds, why is it important that we have enough hospital beds for the most seriously mentally ill who need hospitalization? Isn't a large part of the problem not just the lack of sufficient inpatient beds, but also the absence of any systematic way for the states to determine in a timely fashion where a vacant bed may be located?
That's a really good question. The reality is that when we move to a community-based system, we reduce dramatically the number of beds we have all over the country. It's not just a national problem. It's not just a Virginia problem. It's everywhere in the country. And you know, as Representative Kennedy said, you know, when a person has a heart attack, they're not turned away from an emergency room because the emergency room's full. It's just like when a person commits murder, they're not turned away from a jail because the jail's full. When a person has a mental health crisis, we have to find a bed. And in my view, you know, hopefully the larger number of people who need to be treated can be treated in the community, and we're not going to have to put them in an institution. But also in my view, at this time, we have a shortage of beds nationally for those who have long-term mental health issues that need some period of institutionalization, sometimes 30 days or more. We don't have a capacity in Virginia to provide that service to people.
Dr. Lieberman, you wanted to add something?
If I could add something, Mr. Chairman. This is an egregious problem that is complicated but understandable. What happened was that the inpatient length of stay for most individuals with psychiatric illness in the 1960s and 70s was months, if not years. And they were either in state mental institutions, or they may have been receiving long-term psychotherapeutic treatment in the kind of euphemistically named institutions out in rural areas, like typified by what the Menninger Clinic was. And when payers and the government found out the conditions in hospitals were terrible and people weren't getting better and discharged, and psychotherapy and psychoanalytic treatment wasn't doing anything either for serious mental illness, they said, we're not going to pay for this stuff. The government health insurance, Washington, D.C., when I went to medical school in the 1970s, had the highest concentration per capita of psychiatrists of any city in the country. Do you know why? Because GHI paid for psychoanalysis. That stopped pretty quick when there was no evidence to support it and people started getting concerns of health care costs. So the knee-jerk reaction was to go the other way and to limit length of stay, which plummeted down to now single-digit days as average length of stay. In my hospital, New York Presbyterian Hospital, largest health provider in the New York metropolitan area, the average length of stay the occupancy rate in the hospital and medical surgical services ranges from maybe 60% to 85%. In the psychiatry units, it's 100%, always. And the psych ED is the same thing. But the hospital, which is struggling for financial viability, will never give me another bed because it's not financially desirable to do so. And so we're caught in this quandary. As Senator Deeds said, if we had an effective mental health care system which could deter people coming into it by preventive care, which provided adequate ambulatory care to keep people from having to come into the hospital, we would decompress this, but it'll take time.
Chair, thanks, gentlemen. My time has expired. Chair recognizes the ranking member, Mr. Green, 5 minutes required.
Thank you, Mr. Chairman. I want to thank all our panel. My experience outside of being a legislator as a lawyer doing probate work in the 1980s in Houston, Harris County, I was so proud when we got a Harris County Psychiatric Center managed by the University of Texas Health Science Center. But we have fewer beds there today than we did in 1988. And that's the frustration, I think, seeing around the country. But when I was practicing law there, I was so happy when I found somebody who actually was a veteran, because I could get him into our Veterans Hospital that had real treatment, and we didn't have to wait for a bed. And that's our problem, and I know it's even worse today because of the growth in our population. My frustration back then was that very few insurance policies covered mental health. And I know the Affordable Care Act did much to advance mental health care, largely by extending coverage for mental health and substance use disorders. It required new and small group plans, insurance plans, to cover these services as essential health benefits. In addition to advancing parity of coverage, the ACA authorized the Center for Medicare and Medicaid Innovation, the CMIs, to test innovative models of care. Of the first round of healthcare innovation grants, CMMI 10 were focused specifically on mental health. Mr. Cole, in your testimony, you described the work Community Access has done to create programs that provide innovation and tailored services to people experiencing psychiatric episodes. I understand Community Access received a healthcare innovation grant from CMS to create Parachute NYC, or New York City.
Thank you, Congressman. That's correct. Community Access, in partnership with the City of New York, applied for a grant to create alternatives to hospital care, and the city called it Parachute NYC. It means a soft landing for people in a psychiatric crisis. Then the Parachute program, so there's actually created 4 residences. One in Staten Island got left out again, but one in each borough, as well as enhancing the workforce by adding peers to mobile crisis teams and creating a peer-run support line. So our residents opened first in January of 2013, so we've run it just for about two years. We had almost no guests for the first 6 months. We had 6 guests. We had a capacity for 7. We had over 100 people in the last 5 months. So, and 25% of those were self-referrals. So if you put a service out that is an experience that people appreciate, they will flock to it. People can come and go. People are encouraged to, talk to staff. Our staff are all peers. We had 800 applicants for 14 positions. So we, and then trained people on how to talk and listen to people, and brought in evidence-based practice to do that. New York has made a deal with the Center for Medicaid and the government to reduce actually the usage of hospital use by 25% over the next 5 years, including Dr. Lieberman's hospital, which is part of the reform plan, by creating more respite services, mobile crisis teams. Our mobile crisis teams take 48 hours to go out. In Pierce County, Washington, they take 48 minutes to go out. And a family in crisis needs a response. It needs a place to call, and then they need somebody to respond when the call is made. So Parachute NYC was a package of improving mobile crisis, offering alternatives to hospitalization, offering support lines, and expanding the peer workforce.
Mr. Cole, do you think that program could be replicated around the country? Although I know we have a lot of programs all over the country that actually may not be federal government funding, but actually is coming from the community.
It's a simple model. I think that the idea, and I think the resistance that we faced initially, was that it wasn't going to be safe, that peers are running it, therefore it's not going to be a safe place for people to go. So we had open houses, we had cake sales, we had things, we had people come and meet the staff. The staff went out and did presentations to agencies so they could see who worked there. We also linked to medical facilities and healthcare. So we don't ignore the safeties first. So you take care of people when they come in the door. If you notice a problem, you can seek help. But it's got to be done. It's got to be a system, and it can't be just one thing. It's got to be organized, system-wide. And there's very few places around the country where they've done that. The crisis intervention teams, and a lot of Arlington, Virginia's got a great program. Mental health, police, drop-off centers, very well organized. They meet monthly. That's the kind of comprehensive service that you can put together. So yes.
Thank you, Mr. Chairman. I know I'm out of time, but Ms. Billingsley, I wanted to answer your question. I'll submit it, and we'll get a response about the success with your child. So, thank you.
Chair, thanks, gentlemen. Now recognize the Vice Chairman of the full committee, Ms. Blackburn, 5 minutes for questions.
Thank you, Mr. Chairman, and thank you to each of you. I am going to come to Senator Deeds and Rep. Kennedy and Mr. Rosenthal. And as I said, we've worked on this. Chairman Murphy has done such a tremendous job on this, and we want to have a piece of legislation that we can put in place, get signed into law, and then have that foundation that will work us toward parity. With that in mind, what I would like for the three of you that I have mentioned, and Senator Deeds, let's start with you, to just talk to me, give me the 2 or 3 things that you think are best about the bill that will be most helpful, and then the couple of things that probably you think we need to go back to the drawing board on, and very quickly to the three of you, and then the others of our esteemed panelists, I would like for you to just submit that to us in writing. I think as we drill down and as we get something ready to move forward, give me your thoughts. This is helpful to us as we plan forward.
And honestly, you know, I was provided a summary of the bill, and that's what I read. And so I don't know that I have all the detail to give you to answer that question precisely. And maybe I can do that in writing later on.
That's acceptable.
The part of the bill that I really like are the changes to HIPAA. You know, I hear from so many people. I mean, since my son died, the last 19 months, I get messages, I get email, I get Facebook messages, I get contacted by people all over the country every day, mothers and fathers, older brothers and older sisters who care for a loved one who has a mental illness, who can't get information they're in basically the same situation I'm in. And I think
Okay, so for you, the number one would be the changes to the HIPAA laws.
Yes.
You like that? That is something that would help you as a caregiver.
I mean, nothing's going to help me. I'm done.
Yes,
But it's
sir,
gonna
I
help the next
understand,
person.
but I mean, to that type situation.
Right.
And I appreciate that so very much, and I appreciate your willingness to work with us on this. Patrick?
Thank you, Representative Blackburn. I would say, obviously, we've all spoken about prevention as the main policy we should all adopt. But I don't want this hearing to end up becoming this false dichotomy that it's one or the other. Obviously, payers want to do it on the cheap. So if they can hire a bunch of peer support folks, they're going to do it. And if they can deny inpatient treatment, they're going to do it. So we just have to be mindful that one doesn't preclude the other. I like the recovery model. I'm a beneficiary of the recovery model. But God forbid we use that as an excuse to preclude the medical treatment that people need when they're in crisis. This is not an either-or issue. We need both. And so I'd say that, and I'd finally say this, 42 CFR, if we're going to move forward in the 21st century, we need to have brain illnesses included in your medical record, or else we're never going to get the comprehensive, support that
Okay.
someone needs in their care, and I love that about.
Okay, so we've got HIPAA and we've got a both-and approach, not an either-or.
Yes.
Okay. Mr. Rosenthal?
Thank you. The parts of the bill that I like the best are the focus on integration of health care and mental health care, and the better coordination of criminal justice and mental health. There's no question that so many of our most vulnerable people really have all these issues, and the coordination is essential. In New York, thanks to the Affordable Care Act, we're implementing health homes, which are linking all these systems to work together, one staff person, one record, one plan. The second thing, and I'm really just not sure how to read the bill, but it looked like something we had talked about, Congressman Murphy, about outreach and engagement. You have a section in the block grant section which appears to say that you must have a good outreach and engagement plan in order to get the block grant, and that the strategies there may or may not have to have AOT in them. So I think a lot of us believe that this really aggressive but not coercive outreach and engagement, relentless outreach and engagement is critical, and it seems like you're very focused on that, and I think that's just is tremendous. It's on the front end that we really have to do the most work. And the third thing is the Interagency Serious Mental Illness Coordinating Committee. I think it really brings together all kinds of agencies and needs and expertise. The only thing I would say about that is it should include SAMHSA and the Centers of Medicaid and Medicare It's the #1 funding stream Medicaid is in America, and that's our best chance, the outcomes associated with that, the incentives. The things I like the least, well, assisted outpatient treatment really had its origins in New York in a very big way. I've been working in opposition to that for a very long time, and I do that because I don't believe it's been proven to be an effective strategy. There have been studies, first at Bellevue, that gave everybody better services and compared and gave some court orders, and the study found it was the more and better services that got it done, not the court orders. The legislature was so concerned about that they ordered a comparison between voluntary and involuntary. Am I out of
Mr.
time?
Rosenthal, I'm sorry, my time has expired, and
sorry.
if you can submit
I'll
the
write it
list
to
in
you.
writing. Thank you all so much. Yield back.
Chair thanks, gentlelady. Now recognize the ranking member of the full committee, Mr. Pallone, 5 minutes for questions.
Thank you, Mr. Chairman. I wanted to ask my questions of Mr. Rosenthal. We can't talk about mental health coverage without talking about the Affordable Care Act's Medicaid expansion. Can you comment on how Medicaid expansion has expanded access to mental health and substance abuse services? And I ask that because, to put this in context, 22 states have declined to expand Medicaid at this time, leaving 3.7 million uninsured adults with serious mental illness unable to obtain coverage. And I hope those states will see both the economic and moral benefit of Medicaid expansion, sooner rather than later. And your answer to this question may provide, some reason as to why they should do that.
Thank you. The Medicaid program of the past was a very rigid and limited program, very focused on illness and symptom management, but not, as I said earlier, about all of the domains of recovery that are essential. We now have in this country a Medicaid expansion program and a greater use of Medicaid managed care where the focus is on outcomes and improved services and a diversity of services, including supports for even the social determinants of health, housing, employment, things that really matter in people's lives. So in the expansion, I think, really brings in people who currently are shut out, including people in addiction recovery and some of the programs that they require. So it's an extraordinary time to watch Medicaid reform and Medicaid expansion because I think millions and millions of Americans, without getting access to that, will be shut out and will be subject to poor care and poor treatment.
I mean, is it fair to say that lack of insurance coverage is not only a significant barrier, but maybe the most significant barrier to someone receiving consistent care for a serious mental illness?
Absolutely. And you know where that really turns up is people who are in jails and prisons who lose their Medicaid. It's shut off. And at that critical moment of discharge planning, if the Medicaid is not in force, people fall within the cracks. I read somewhere that people in addiction, if they don't get help in 20 days, 30% of them die. It's a very strong figure. So Medicaid access is critical, and in that system in particular, people are leaving jails and prisons without the services they need, and that's why we get so much reincarceration and tragedy.
All right, I wanted a second question about programs of regional and national significance, the PRNS. H.R. 2646 would create new grant programs that would be funded through a 20% cut on programs of regional and national significance and on SAMHSA's general funding authority. I wanted to focus on the possible effect of a 20% reduction in funding for PRNS grant programs. SAMHSA's Center for Mental Health Services currently funds mental health first aid training for teachers and other adults who interact with youth. That training equips them with the tools needed to detect and respond to mental illness in children and young adults. That PRNS program received $15 million in fiscal year 14 and 15 to provide grants to states and local education agencies. So, Mr. Rosenthal, if SAMHSA's PRNS authority was reduced by 20%, $3 million would potentially have to be cut from that program. In general, what would a 20% cut in grant funding for community programs mean to those existing programs?
Well, I think it would be a loss of access for many, many Americans in need. Certainly the mental health first aid program has been so critical in educating the communities, the police, other important groups, and if that is cut, then that many communities and that many people and families but won't have the benefits of first aid. I'm not familiar enough with all of the programs of regional and national significance, but I reviewed them briefly, and there are a number of recovery programs that if they were cut by 20%, again, where there's a real emphasis on AOT and not enough, I think, on the recovery side of things.
Well, in addition to cutting mental health programs, H.R. 2646 would cut substance abuse programs to pay for those new mental health programs. A program that could be cut is funding for states to enhance or expand their treatment services to increase capacity and access to evidence-based medication assistant treatment, or MAT. And the fact is, America is facing a public health crisis related to the misuse and abuse of opioids, and we should not be cutting, in my opinion, any funding for that or for other SAMHSA substance abuse programs. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the Vice Chair of the subcommittee, Mr. Guthrie. 5 minutes for questions.
Thank you, Mr. Chairman. Senator Deeds, I used to serve in the Kentucky State Senate, and you mentioned in your testimony that you had bipartisan efforts at the state level. You didn't really elaborate on those. You just kind of, for a few minutes, or about a minute or so, what you did, and then how the federal government could help states doing what you want to do there.
At the state level, you know, when I went back to the General Assembly after just a few weeks after all of this happened to me, my scars were red and my eyes were too. People there knew me because I've been in the General Assembly for a long time. I'm a bipartisan guy. I'm a partisan Democrat, but I've got friends on both sides of the aisle. They knew my son because he'd been on the campaign trail with me for years. So I was able to cobble folks together to get things done. But the reality is that funding is not as consistent as it needs to be across the board. We need better organization. And what this bill does in many respects is it takes funding and reorganizes it in a way that makes more sense, I think, makes more sense for the states, makes more sense for the country.
Well, thanks. And I was going to ask Mr. Kinney, my friend Patrick, this, but you mentioned HIPAA and how the reforms in HIPAA, how did HIPAA specifically block what you were hoping to do, or how did it affect your situation? I understand that you can't get as a caregiver, you can't get the information you need.
Well, I couldn't get psychiatrists to talk to me or to even return my calls. I couldn't get people in hospitals to tell me anything about what was going on with my son. And he was wary of me in the first place. So when I got him to go with places, I tried for a long time to get him to sign a power of attorney or to sign a medical power of attorney to give me access to information. I tried to get him to give me that authority on some forms that other people had prepared for him, and he just wouldn't do it. So, and the providers wouldn't talk to me. I had one provider that sat down and talked to me, probably broke the HIPAA law, and maybe it is a lack of understanding of the law. But if it is, it's widespread. I had one person, I got an anonymous letter just about 4 months ago from a person who told me that he or she had provided care for Gus and had told me some things that touched my heart about their treatment of him. I just didn't have the information beforehand. You know, it seems to me. You know, let me just tell you. One woman called me, or she called my office. She tried to get her adult son committed through an involuntary process. She was successful, but in the hospital they wouldn't tell her where her son was going. So she couldn't get him his things. She couldn't talk to anybody there about his experience. That facility wouldn't even return her calls. They just put him on a bus and sent him home. How in the world is he going to be kept to schedule? Is he going to take his medications? Is he going to keep his appointments if somebody doesn't know it? That's what this.
Thanks. I have one more question. Well, it's not really a question, but Ms. Billingsley brought up some concerns, and we want to solve problems, not raise more concerns. I talked about the PAMI program, and if I could yield to my friend from Pennsylvania to address some of the concerns that you brought up, I would like to do so.
Well, let me just say this. With regard to some things with the protection advocacy issues, I can't say that there's much that this panel has said that I don't agree with. And it sounds like some clarification of wording. Our bill does not require assisted outpatient treatment. It does not. And that's a misnomer, and I see that in the minority memo. So let's make sure we're clear on that. We recognize it can be valuable for some people, particularly those recycling in and out of jail, those who have history of violence. We just saw that happen down in Dallas, Texas. I think it can help in some cases, but it's not a panacea. But I want to make sure that we are focusing on this and worded this in such a way that people can get help and can't get that advocacy. It is against federal law to use it for lobbying, and I don't intend to change that law. But I want to look at something that does need to change, and just follow up on what you were saying to Senator Deeds about some individuals have claimed that with regard to releasing the information all under HIPAA, it has to be, quote, is necessary to prevent or lessen a serious and imminent threat to the health or safety of a person or the public. So that's the limitation, and do you agree with that kind of limitation?
I might take it a little broader, but I think that protects the person's privacy. Somebody has to make a decision that it's necessary that the person doesn't understand what's in their best interest, and that the caregiver will provide for that.
Which is important, and that's where I think our bill tries to broaden that. If that person is not aware, to provide you with a diagnosis, treatment plan, time and place of the next appointment,
That's right.
medications, that would be helpful to you as a parent?
That would be very helpful. Critical.
I'll get back to my questioning later. Thank you.
Thanks. My time has expired. I'll yield back.
Chair thanks the gentleman. Now recognize the gentlelady from California, Ms. Capps, 5 minutes for questions.
Thank you, Mr. Chairman, and thank you all for your amazing testimony. For too long, mental health has been left out of our discussions about health. I'm happy that members of this committee on both sides of the aisle have a shared interest in addressing this important issue. My background as a public health nurse, worked in our community schools. This is an issue I know well. I have a brother who has a history of being bipolar. I know it personally very well. Thankfully, we've made great strides in recent years, most notably that all plans must now follow mental health parity rules. Many previously uninsured and underinsured individuals with mental illness now have access to insurance. This was the greatest expansion of mental health services in our history, but now one that needs to be built upon. And as written, I am concerned that my colleague Mr. Murphy's bill does not comprehensively advance this progress enough. We need to work together to do so, because it does little to address mental health issues before they reach that crisis level, help individuals after the crisis point is passed. It pits mental health and substance abuse services against each other, despite the fact that for so many individuals, these are intertwined ailments, and needlessly injects partisan politics into the mental health space by attaching extraneous abortion language. We don't need to be doing that here. It's not a way to move a bipartisan bill forward to make meaningful change. Our nation has a history of reacting to mental health issues in a very erratic way, swinging from one extreme to another. We need to stop this swing and enact thoughtful, evidence-based policies if we really, truly want to make progress. I'm hopeful that today's hearing is going to help us look beyond a particular bill and help us have that constructive dialogue to move in a positive way. Mrs. Billingsley, at a previous hearing on this issue, I was particularly moved by a woman's testimony where she described the abuse that took place in her group home and how the protection and advocacy for individuals with mental health program, PAMI, helped shut it down and bring her and her housemates justice. I'll never forget her testimony. Similar to what you have talked about today, it's equally notable. But as you noted, the Murphy bill would tie the program's hands to protect these individuals from unlawful discrimination and from educating policymakers like ourselves about the issues that these individuals face. I think that seems really short-sighted. If the PAMI program is prohibited from advocating for the rights of an individual with mental illness, where will families turn to ensure the enforcement of laws and regulations?
I don't know where they would turn. And quite honestly, I don't know where our family would be if we had not had their help. I can't even imagine where we would be. I often think, and coming here today has brought back quite a bit of this journey for our family. It's possible my son wouldn't be alive today. It's quite possible because of the downward spiral he was in, and we were no longer able to help him. So if that funding was not there, I don't know what we would have done.
Programs like PAMI are so critical, and you said it, to ensuring that families and individuals with mental illness have advocates ensuring that their rights are protected. We don't want, as it seems to be the case in this bill, to tie their hands, and that's another indication in my mind that we can do better. One bill I'm particularly interested in was written by my California colleague, Representative Matsui. Her bill, it's the Including Families in Mental Health Recovery Act of 2015, would clarify HIPAA privacy rules and would educate providers, patients, and families about the law as well. Mr. Rosenthal, may I turn to you? Do you think health providers adequately understand what HIPAA permits if a patient is in a crisis situation? In other words, do we have a problem with provider education?
Absolutely.
Or do we need fundamentally to rewrite our privacy laws?
I think education is critical. I think HIPAA, as I understand it, and certainly as, and also sort of codified, if we could codify OCR, the Office of Civil Rights sort of guidance, would make it even clearer. But I know that providers at minimum are confused or frightened, and at worst are hiding behind HIPAA rather than really talk. They can listen to families now. They may not be able to disclose everything, and there are circumstances where they can and should, and they don't. So I think, absolutely, I think education is critical. We can't do enough of it.
So that is an indication of the ways that we've got to move past where we are today, even considering this bill. I'm out of time. I'll yield back.
Chair, thanks, gentlelady. Now recognize the gentleman from Illinois, Mr. Shemkus, 5 minutes of questions.
Thank you, Mr. Chairman, and thank you all for being here and for my colleagues for their great questions. I just would encourage my colleagues that if we want to have an opportunity to really move a bill, we're going to have to come together and not be positive and just tweak the language and work this through. My colleague, Mr. Murphy's worked real hard. Patrick, it's great to see you again. Senator Deeds and the folks' testimonies are just heartbreaking. And so the easy question, how many of you on the panel are parents? Raise your hand if you're parents, okay? Everyone's a parent. So my question is, when do we stop being a parent? I don't think we do. You know, my mom and dad, thankfully, are going to celebrate their 65th wedding anniversary. And if I do something wrong, they're in my face. So this HIPAA debate, oh, I said that, didn't I? Dang. That's our secret. Don't tell anybody. This HIPAA debate is very, very important, and I think we really need to get it right. You know, I still have young, not young, but young men who, you know, some of this onset comes at different times. And I fear the day where they need help and we can't get access to information. And so I'm very encouraged by the talk and this whole debate because we want to be engaged. My question is to Dr. Lieberman on asking you if you have any sense of what kinds of clinical outcomes are associated with the emergency department overcrowding for patients requiring medical or psychiatric services.
Well, the overcrowding and the increased demand relative to capacity simply sort of backs up people who are waiting to be seen, makes the healthcare personnel kind of rushed in the process of being able to do the evaluation. And then if the disposition is hospital admission, which it frequently is because there's a paucity of available beds, they must sit there. In New York State, there's a law that you have to make a disposition of somebody in an emergency room within 48 hours. It sounds long, but many people sit there for longer. We've had patients in the emergency room for as long as 6 months. That means they have to be fed, bathed, and the reason why this occurs is because if you have what's called an intellectual or developmental disability, autism, Fragile X, any of the genetic neurodevelopmental disorders, and a complicating psychotic disorder, there's no place for you to go. So it's ridiculous. But it really prompts me to comment on some of the discussion we've had here about the various programs, community access and so forth. Harvey Rosenthal's excellent work as a rehab director. We're not having a discussion about excluding programs. This is all part of a comprehensive effort. Mental health care is disease management. It's not simply a doctor giving a pill or a rehab counselor, finding housing or teaching a skill. When you have cancer and you have to go, let's say you have breast cancer or prostate cancer, or you go and make a recommendation, surgery, possibly radiation and chemotherapy. If the surgery disrupts your musculature, you might need rehab. Oftentimes there's a psychiatric component to it. All of these things are part. Right now we can't provide those because there's not a co-located availability of these services and a revenue stream for financial reimbursement. So it's all fragmented, and as a result of this, and I would think, and I appreciate the effort here, because this, if anything can rise to be a bipartisan cause, this should be. This is not like we have to discover something new or mysterious. The expertise, the tools are available. We simply have to develop the policy to be able to orchestrate it. And what concerns me is that ideological issues are permeating and kind of diverting attention from the real issues. If you look at SAMHSA's website, where they have a list of 360 plus interventions, there's no mention of medication. Now, I'm not a cowboy doctor that's going to prescribe, massive drugs and say, see me in a month to people. That's not what physicians do, and it's certainly not what psychiatrists do. But how can you have a list of interventions with no medication? It's like if you're going to go, it's like Stephen Jobs. He refused surgery because he wanted to try a naturopathic approach. Shouldn't be exclusionary. We need to have a big picture approach to this in order to be able to really deal with this problem. And how long is it going to take us to appreciate it? How many new towns, how many Aurora, Colorados, how many Jared Loeffners is it going to take for this to happen?
My time's expired, so thank you.
Chair thanks the gentleman. Now recognize the gentlelady from Illinois, Ms. Schakowsky, 5 minutes for question.
Thank you, Mr. Chairman. I apologize to the panel. There are concurrent hearings going on. I want to especially welcome my friend Patrick Kennedy for being here. And of all the ways that you've contributed, the many ways, I want to thank you for decreasing the stigma attached to mental health issues. Thank you for that, Patrick. Before I begin my questions, I want to first say I am very concerned that we are unnecessarily seeing anti-abortion language included in this bill. We do not need to attach this kind of restrictive language on programs that help to prevent suicide and provide transitional housing for people with mental illness. And moreover, the language in this bill actually goes a step beyond the Hyde Amendment and restricts funds from being used to refer a woman to abortion services. And if anything, a provision that would probably guarantee increased mental anguish. Women deserve to have access to the full range of health services at a minimum, have a right to know what services are available to them. So this language continues a dangerous precedent of attaching language restricting a woman's access to reproductive health services in bills that address different topics. But let me move on. I'd also like to address the drastic changes H.R. 2646 would make to the protection and advocacy for individuals with mental illness program. In Illinois, our Protect and Advocacy organization, Equip for Equality, has worked tirelessly to advocate for individuals with disabilities for 30 years. Not only has Equip for Equality secured housing and services for individuals with mental illness, but they have also worked to affect public policy. For example, they worked with state officials to create an adult protective services system which works to prevent abuse, neglect, and exploitation of adults with disability. They also have advocated for the continuation of services that allow medically fragile children to remain in their communities rather than in institutions, and yet this legislation would actually prevent Equip for Equality from doing this important work. So, Ms. Billingsley, I want to thank you so much for joining us today to share your personal story of your family and son, Tim. As important as it is for PAIMI to address abuse and neglect, many people like Tim face hardship due to their mental illness because of discrimination and navigating the complex mental health care system. Families are often not able to find the help their family member needs regardless of how hard they try. I've actually experienced that in my own family. You said in your testimony that Tim is just 22 years old. Could you further elaborate on how Tim's illness manifests itself and why it is important to Tim to be in the community?
Tim is going to be 23 next month, so he's pretty excited about that. The way his mental illness manifests itself is that he is highly needing to have structure on a regular basis for him. And he is a very talkative person, and he is very social. And if he is isolated for very long, he acts out with that. That goes against what he wants to be around with or be with people. He also has a seizure disorder, and I bring that up simply because he needs to have family and community around him to help take care of that issue if that were to come about. And we've had a few situations with that. He currently lives in a home with 5 other young men, and he is very hasty to tell me it's time for you to go, which took me a little getting used to be quite frank. But he has a full life without me, and he needs that community setting to live his life well beyond the time I'm here.
So let me ask you this. Do you think you would have been successful in securing Tim's right to stay in the community if the Disability Rights Center of Kansas had not been allowed to advocate on his behalf?
No, there's no way.
What would have happened then?
We wouldn't, it's kind of similar to what else has been shared here today. We wouldn't get phone calls returned. We wouldn't get responses when we asked about programs. We were on waiting lists for services during a time in which my son would become violent at home. And there were concerns with the safety of our own family. If we had not had their intervention, as has mentioned here, within 48 hours when we needed it, we would have had to have been hospitalized, I'm sure.
Thank you. I would like to ask unanimous consent to put into the congressional record, Congressional Research Service memorandum.
Without objection, so ordered.
Thank you. Thank you very much. I yield.
Chair now recognizes the gentleman from Pennsylvania, prime sponsor of legislation, Dr. Murphy. 5 minutes for questions.
Mr. Chairman, before I start, I just want to ask that a couple of things be submitted to the record. One is a GAO report this committee requested called Mental Health HHS Leadership Needed to Coordinate Federal Efforts Related to Serious Mental Illness. Second is the GAO report requested by this committee called Mental Health Better Documentation Needed to Oversee Substance Abuse and Mental Health Service Administration. Third is from the HHS Office of the Assistant Secretary for Planning and Evaluation called Evidence-Based Treatment for Schizophrenia and Bipolar Disorders in State Medicaid Programs. And finally, a list of materials I'd like to submit for the record on the statement from the American Roundtable to Abolish Homelessness and letters of support from the American College of Emergency Physicians, the National Council for Behavioral Health, the National Alliance on Mental Illness, the American Psychiatric Association, the American Academy of Child and Adolescent Psychiatry, and the American Psychological Association.
Without objection, so ordered.
Thank you. It is an amazing day that all of you are here and Congress has gathered to talk about such a critically important subject. Let's not forget that. We have a massive amount of common ground here. We have to link arms together and do this. And I thank my colleagues for their thoughtful comments on this as well. Let me dig down in a couple of these things which I think are important in this bill. Mr. Gianfrido, in this bill we lay out a greater emphasis on secondary and tertiary prevention and say you have to put some more dollars into child and adolescent areas rather than wait till later on. Could you describe why that is important to you, why you think it's important to focus on those areas?
Well, I think it's critically important to focus in on children. You know, the data are 50% of mental illnesses manifest by the age of 14, 3/4 by 25. But for a lot of us, the statistics don't matter. My son was 5 when he developed signs and symptoms of schizophrenia. And he got the 10-year delay that everybody else gets by the time he got his final diagnosis, 10 years. That we lost opportunity after opportunity to change the trajectory of his life. That's one of the reasons he's homeless now, not by his choice, but by choices we made as policymakers to do that. It's critically important we move upstream. We've got to arrest this at stage 1, 2, and 3. We can't keep waiting till stage 4. We can't keep waiting for crises to occur. We can't keep waiting post-crisis. We have got to move upstream. That's why it's important to me.
And I might add for my colleagues, what I mean by primary prevention is what we tell everybody. Secondary prevention is now you've identified a high-risk group, and tertiary is someone who's with symptoms. And that's important because as we go through in the grant programs, what the GAO report said about SAMHSA is, quite frankly, they weren't documenting, they weren't evaluating. Programs that got grants didn't stick to their grants, so it is important we have that oversight. I also want to note with regard to the issues with regard to Medicaid services here, that in this report from Office of Assistant Secretary for Planning and Evaluation, it said only 45% of beneficiaries with schizophrenia and 35% with bipolar disorder maintained a continuous supply of evidence-based medications and received at least one psychosocial service during the year. In other words, these reports are saying our system is failing pretty bad in this. Patrick Kennedy, you and I have talked a great deal about this issue of an assistant secretary and their role to get the federal government coordinated in these symptoms, to follow through on parity, and to report back to Congress. You've been here. You understand what it's like. What do you see the value of having someone go through these 112 federal agencies, get the data from the states, and keep Congress's feet to the fire in this? What do you see the value of that in moving forward in the long run?
Well, thank you, Representative Murphy. I'd first, to your previous question to Paul, would say we could solve this crisis tomorrow if we intervene on first incidents of schizophrenia. There's no mystery in this country how to avoid the over-hospitalization and crisis management. We're picking up the pieces after people have fallen off the cliff. We know what to do. Intervene right away with first onset. Don't let the time lapse. And as Paul said, you permanently change the trajectory of those people. So for people who are interested in return on investment, your investment is a lifelong disability is averted if you do that wraparound services first incident. So, Representative Murphy, I appreciate that being a major focus. The RAISE work that's being done now is the model. Naples is the model. The prodromal phase, scientifically, before symptoms is really what our holy grail should be. And we can do that with scientists like Jeff Lieberman. To the answer on accountability, we're in a new post-parity world. We have the legal infrastructure to appeal when people aren't being treated equitably under the parity law. And I appreciate the fact that in this legislation you have a specific GAO report evaluating non-quantitative treatment limits. That's the secret way that insurance companies deny care. They keep it behind. Of course, we've eliminated the quantitative treatment limits. That's premium discrimination, copay discrimination, lifetime limit discrimination. That's gone. So now where have the discrimination moved? It's moved to this non-quantitative treatment limits. If we expose that, which your bill, among many other things, calls for greater transparency and accountability, I'm telling you, you're going to see a sea change in the way that we move towards this problem, because we're not going to be waiting for it to become crisis. It's going to be evident to insurers that it's more cost-effective for them to intervene early. So I appreciate that, and the state reporting is key, because as you acknowledge in this bill, it's the state's mandate to continue to work in implementing this law. We need to have an accountability structure to see how they're doing, and I appreciate that also being in this legislation.
Chair, thanks, gentlemen. Now recognize the gentlelady, Ms. Castor, 5 minutes for questions.
Well, thank you, Mr. Chairman and Mr. Green, for calling this hearing today. And I want to thank the panel for relaying a sense of urgency for the Congress to act when it comes to mental health. And thank you for your expert recommendations on how to improve the bill today. And Congressman Kennedy, it was great to see you a few months back at the Florida Mental Health Research Institute in Tampa at the University of South Florida. They presented Congressman Kennedy with the Humanitarian Service Award that's very well deserved. So it's great to see you. I want to keep the focus on implementation of the Mental Health Parity Act. And there is an important provision in the draft bill that would require the Department of Labor to submit a report to Congress identifying federal investigations conducted or completed during the previous year regarding compliance with parity in mental health and substance abuse disorders under the Mental Health Parity Act. Remember, that act enshrined in law the principle that mental health is equivalent to physical health, and the law required group health insurance plans covering mental health and substance abuse services to cover them at parity with physical health services. Then the Affordable Care Act extended this principle to the individual health plan market. It also requires that all expanded Medicaid programs, as well as individual and small group health insurance plans, cover mental health and substance abuse services as part of the essential health benefits package. That is critical. The ACA expanded these benefits and parity protections for 62 million Americans. But Congressman Kennedy, in the beginning of your testimony, you referenced the difficulty with implementation. You're hearing about insurance companies' compliance or non-compliance with the parity requirements. Is that accurate?
Absolutely accurate. And if members want to make a difference tomorrow on getting more people care than they have today, write a letter to Secretary Perez from the Department of Labor, because Secretary Perez can issue greater guidance on all ERISA plans. That's employers' insurance plans, that this should be a greater evaluation on whether they're complying with a federal law. He can issue guidance tomorrow. He needs to hear from you that you want him to do that, because 65% of the health market is that employer-sponsored health care. And our veterans, by the way, are going to depend on their health plans, if they're employed, having coverage for their signature wounds of war. 2, you could write a letter to Secretary Burwell from HHS. She has the authority today to issue greater disclosure requirements on all insurance companies so that we can better understand how they do medical management. Because as you know, Representative Castor, the key to this is the utilization management, how they move those things around. We, under parity, by necessity, need to know how to compare the way they do utilization management for the mental health patient to the way they do utilization management for the stroke patient, for the cancer patient, for the diabetic. If we know how to draw those analogs, we can enforce parity, because the law would require that they do something different than they're currently doing.
Other panel members, are you hearing about difficulties with implementation of the important goals of mental health parity? Mr. Gianfredo?
Absolutely. I think that everybody understands that the law has changed, but the implementation of the law hasn't fully taken place yet. And we deal with this every single day at Mental Health America. We are hearing a lot about this and strongly endorse efforts to try to make certain that we realize all the benefits of parity for all the people we care about.
Mr. Rosenthal? Yes, go ahead.
I can add that when I was in my role as president of the American Psychiatric Association, we had to make decisions about which litigation to pursue against various insurance companies that were denying benefits or not complying with the parity law. And what it ultimately came down to was the fact that we had a very strong case in almost all instances, but there were such deep pockets on the side of the insurers that financially they just drained us. And so it became a much more complicated sort of battle to fight, and I think we're still engaged in that battle.
Well, I want to thank you all. I think with Mr. Murphy's help, we can look at ways to improve this. If you all, when you're submitting comments back to the committee, would make some recommendations, specific recommendations here. And I also appreciate Ranking Member Pallone bringing up the Medicaid expansion, the importance of it. The state of Florida, unfortunately, just last week, rejected a Republican state Senate plan to expand Medicaid in Florida. That leaves about 800,000 of my neighbors across the state of Florida in that gap. It leaves billions of dollars of our taxpayer dollars here in Washington rather than bringing them back home. So if any of you all can talk to policymakers in the state of Florida, please relay to them how important Medicaid expansion is for mental health services. Thank you.
Chair thanks the gentlelady. Now recognize the gentleman from Virginia, Mr. Griffith, 5 minutes for questions.
Thank you very much, Mr. Chairman. Thank you, members of the panel, for being here this morning, particularly Senator Deeds. It is so great of you to be here. Your story is obviously very compelling, and when the incident occurred with your son, the entire region was affected by it, and we appreciate you being here. That being said, one of the reasons I've asked to be on this particular subcommittee was so I could talk about rural health care issues. And how long have you been in the state legislature? 24 years?
24 years. Got there one term before you.
That's what I was thinking. And you live about, what, 9 or 10 miles outside of the 9th Congressional District?
I used to be one of only 2 members in the state Senate that was on the dirt road, off a dirt road caucus, but the other fellow retired. So I'm the last one that lives on a dirt road, off a dirt road.
There you go.
Just a little about 9 miles out of that district.
So that brings up the issue. You worked very hard and got some great legislation through in Virginia to make sure that there was a mental health bed registry available to the people of Virginia. But I noticed in an article late last year, that Eastern State is getting a lot of patients because they're the location that has beds, and they're the beds of last resort. And I'm wondering if we need to be thinking about encouraging the states to participate in a national bed registry, because you're also not far outside of the 9th. How far are you from West Virginia? And
I'm not far from West Virginia at all, and
10, 15 miles?
probably a little bit further than that, but not very far. 25 miles. A national registry might make some sense. It might make some sense, but as you know, and we in Virginia have also turned down the Medicaid dollars. They provide insurance to about 800,000 Virginians, or 400,000 Virginians, and about 162,000 of them have serious mental illness. Be significant for us.
And I will agree with you that mental health issues are things that we need to take a look at and be very serious about. I am also concerned about the HIPAA requirements that you weren't able to know. Whether it's a misunderstanding or not, we need to change the language to get rid of the misunderstanding,
Yes.
to make it clear. I think this bill does a lot of that. One of my concerns is and I know you've only read the summary of the bill, is that in the sections on HIPAA, we get family members involved, which I think is great. My concern is the family member, and I know you have practiced in this area, or at least most rural lawyers have, where somebody has abandoned the family when somebody's a juvenile. And do you think it might be helpful if we put language in there? We've excluded people who have a documented history of abuse, but do you think it might be helpful if we also excluded family members who have abandoned a juvenile before the incident, obviously as an adult, but when they were a juvenile, abandoned them?
I think that language needs to be clear. The summary I read does make clear that there has to be some kind of caregiver relationship between the family that's going to have information and the person that's affected.
And I appreciate that. I have a little bit of time left. It is great to see you.
Thank you very much.
And appreciate you being here. Is there anything else that we haven't touched on that you wanted to touch on?
I think we've touched on a whole lot. Yes, sir. Thank you.
Right.
Thank you very much.
And we have.
Gentlemen, yield time?
Yes. Well, I can. Gentleman from Pennsylvania has requested my time, and I would like to yield to Mr. Murphy.
I thank the gentleman from Virginia. Dr. Lieberman, I want to clarify something about HIPAA, because I hear a lot of talk about it, but you're the only one in this panel, as I understand, who's a licensed provider who has to follow HIPAA laws. In that sense, in your doctor role there, is it just a matter of getting education out to other providers and saying, if only you follow this, everything's going to be fine? Or do you think there needs to be some changes in what you're allowed to tell loving, caring family members who are the provider? What is it that you think?
You're referring to in terms of the HIPAA?
In terms of
legal
HIPAA, I
restrictions?
mean, the restrictions on HIPAA now, what you're allowed to tell someone, is it just educating them, or do we really need some changes?
Oh, it's certainly more than education, because there's a medical legal aspect to it that healthcare institutions are cognizant of, and doctors have the fear of God placed in them by not just their hospital CEOs, but also the personal injury lawyers.
So right now then, and along those lines, if you were seeing Cree Deeds, and he said, can you tell me about my son? Can you just tell me what is his diagnosis, when's his next appointment, where is he? I want to get him there. Would you be allowed to say that as existing lawyers now?
Well, strictly speaking, no. If he's an adult, if he's over age, but if you did it, you'd be doing it at your own risk, because you could be sort of challenged. Doctors often do that, but I don't want to get into that, because
That helps
it's the common sense thing to do.
Okay, thank you.
I yield back.
Chair, thanks, gentlemen. I recognize the gentlelady from California, Ms. Matsui, 5 minutes for questions.
Thank you, Mr. Chairman, and I want to thank all of you for being here today. your testimonies have been very compelling, the full range of mental health. And first of all, let me just say, I agree with Congressman Kennedy about the continuum of care. We should not allow prevention, intervention go against the serious mental illness. This is a continuum of care. This is what we're talking about today. And the emphasis should be on the mental health of an individual. And I believe in prevention and intervention at the early end and all the services that have to be provided. And that has been my history. I've always been feeling that way. And I think that what's really important here to look at, too, is the fact that we have been focusing many times here on serious mental illness because we know how tragic that is. Whether or not it ends tragically or not, I know in my family, I have a sister who's been severely mentally ill for a long time. And during that time, she really did not have the care because it was a long time ago. I think today, she would probably be functioning much better, much like your son, Ms. Billingsley. But I will have to say this. I have been affected very much by the tragedies that have occurred. I have a couple of friends who have adult children who have, they felt, been limited by not being able to assist them. And listening to you, Senator Deeds, I feel that pain again. And I thought that the importance of this bill, because it covers such a broad range, and HIPAA has come up so very often. And I think that HIPAA should be not looked at as an enemy here. And we can't use it as an excuse either. I think we really need to figure on what can we do with HIPAA. And I've spent a lot of time thinking about this and also asked myself, what can we do about these situations when it feels like there's no communication and no one to turn to? And I really thank you for working with me to answer that question, specifically for these issues about sharing information and communications between providers and caregivers. We have to walk a fine line here. We must protect the patient's right to privacy and protect them from those who don't have their best interests at heart. But we must also empower the families and loved ones to be able to help. I think my bill strikes that balance. It's not a wholesale change. I don't believe we can do that because HIPAA should cover both mental and physical illnesses. It just can't be one versus the other. This bill is really supported by mental health advocates that really fall on both sides of mental health policy issues, as well as groups in between. Groups like the American Psychiatric Association, the Bazelon Center for Mental Health Law, the Mental Health Association of California. And additionally, I thank Congressman Kennedy and the Kennedy Forum for recognizing the importance of this bill. I thank NAMI, the Treatment Advocacy Center, the National Council for Behavioral Health, the American Psychological Association, and others for their help. I really feel that this is something where we just can't just say we're going to change it. We have to look at it to find out how we can change it. And I believe that this bill that I've introduced strikes the right balance. And Congressman Murphy, I also believe, too, that your bill is something we can work with and like to work with you on it. And I think you've heard from people on my side of the aisle that they feel that there are really good points to this. And there are adjustments that have to be made. And I think people on the panel have expressed the same also. So I feel strictly that today we should feel heartened that we are actually drilling down and trying to find some solutions to this. And that, to me, is probably the most important outcome of this, because as we move forward, we pledge to do something here that makes real sense. And just to comment on my bill here, Mr. Rosenthal, can you describe any situations where it would be important to protect the patient's right to privacy?
I would say that I'm struggling for a little bit here. I was caught off guard, sorry. I think that patients really, really want to feel a sense of integrity and choice. And I think if they are really already feeling fearful, don't want to feel like their caregivers and the therapists are talking whenever possible about them without them.
Okay, can you think on the other side of this? Situations when it be appropriate and even necessary for a provider to communicate or
Absolutely.
share information with the patient's family.
If somebody's health and welfare and safety are at risk, the person or someone else, I think that's critical. So I think those are critical sort of considerations.
All right. I yield back. Thank you.
Chair thanks gentlelady. Chair recognizes Dr. Murphy for a unanimous consent request.
Mr. Chairman, just to correct the record on the misrepresentation or perhaps misunderstanding about abortion, I ask that S. 1299, the Garrett Lee Smith Memorial Reauthorization Act, authored by Senator Jack Reed of Rhode Island, be introduced into the hearing record. It's Senator Reed's legislation endorsed by the American Foundation for Suicide Prevention, which is identical to the language in H.R. 2646, the Helping Families of Mental Health Crisis Act on Suicide Prevention.
Without objection, so ordered. Chair recognizes the gentleman from Florida, Mr. Bilirakis. 5 minutes for questions.
Thank you, Mr. Chairman. I appreciate it very much, and thank you for holding this hearing. Very important hearing. Last December, I had the pleasure of hosting Congressman Murphy in Florida for a mental health roundtable with stakeholders from the community. I commend him for the extensive amount of time he put into addressing mental health and substance abuse disorders. I also serve on the Veterans Affairs Committee, where we have extensively focused on mental health issues plaguing our veterans, our true American heroes. In 2012, Time magazine wrote that more U.S. military personnel, sadly, have died by suicide since the war in Afghanistan began than have died fighting there. Mental health is an important issue, and I'm glad we're addressing it. Thank you, Congressman Murphy. Question for Dr. Lieberman. Dr. Lieberman, training for law enforcement that addresses how officers can best approach individuals with mental health or substance abuse issues has been extremely important in my community. Training programs that establish a partnership between law enforcement and mental health groups have effectively been implemented in my district. Since this legislation provides the creation of such programs, can you provide some insight about what effective training might entail? What should law enforcement be aware of when encountering individuals with mental health or substance abuse disorders in the line of duty? How could a lack of training cause an escalation in these encounters?
Thank you for that question. This really is a very important but also unfortunate situation that's arisen in which the law enforcement and criminal justice system has become so intertwined with mental illness and mental health care. Every time I see, a terrible story about a mentally disturbed individual being subdued and possibly injured or killed by police, I'm thinking, why are the police called upon to be first responders? That's really not their training. And similarly, in correctional officers, in jails or prisons, because of the increasing number, that's not their training. And even if they do have some in-service training about this, it really is not sufficient. So I think both criminal justice, and it's interesting you asked that because just this past Friday, I was speaking to 500 attorneys in the Manhattan District Attorney's Office. They asked me to come down to speak to them about mental illness, what the nature of it was, what it looked like, and also how could they try and adapt so that they could better manage the process of judicially reviewing cases of individuals who clearly had mental illness. So this is a growing problem. I think training is important, both for the police as well as for the criminal justice system. But frankly, if we're going to basically launder our mentally ill through the criminal justice system, both juvenile and adult, we probably need to have mental health professionals embedded with the police and more present within the prisons and the jails. This is the new normal or the new reality, and we need to provide care where it's required. I was having a conversation with individuals at that meeting on Friday where I offered the observation that in jails you have, in adult prisons you have people principally who are adults who are either psychotic, with schizophrenia, bipolar disorder, possibly psychotic depression, and substance abusing. Predominant diagnoses. In the juvenile detentions, it's kids who have what are regarded as antisocial behaviors and conduct, but in many respects, I would even venture to say it's the majority of these individuals start out as individuals who have learning disabilities, or what's scientifically called pediatric cognitive disorders. They have dyslexia, they have ADHD, they have nonverbal learning disabilities, and they can't connect with the world socially, educationally, and because they aren't succeeding, they're getting kind of negative feedback, they react to it in a obstreperous or disobedient way, and that leads them down this path, and they end up in prisons. So it gets to what Patrick was saying about, we're sort of addressing this downstream after closing the barn door after the horses have left. But either we give a modicum of training to our law enforcement and correctional people, or we embed mental health professionals in it, or we really go for the big solution, which is preempting the flow of individuals into the legal system to begin with.
Thank you. Thank you very much. I'll yield back. I don't have any more time. Thank you, Mr. Chairman.
Chair thanks, gentlemen. Now recognize the gentleman from Maryland, Mr. Sarbanes, 5 minutes for questions.
Thank you, Mr. Chairman. I want to thank the panel. Patrick, welcome back. It's great to see you. I was talking to Dr. Nancy Grasmick the other day, who I know is working with you on brain research and affecting early childhood. And she's incredibly excited about the work that you all are doing together. And I worked for her for 8 years, so I can tell you if she's excited, it's got to be good stuff. So congratulations on that, and thank you for your testimony here today. There's no question that we still live in a world where when we see physical pain, our impulse is to treat it, and unfortunately when we see mental pain, our collective impulse often is to look in the other direction. And the first step towards remedying it, a critical step, obviously, is to make sure that our healthcare system acts with the kind of parity that Patrick Kennedy and others fought so hard for, and is now embedded in the Affordable Care Act. There is this tension as we think about how to distribute resources across a healthcare system that is more sensitive to issues of mental health, between sort of where along the spectrum do you place the resources to maximize the positive impact you can have when you're talking about people that are on that spectrum of illness. Intervening in an earlier stage, maybe intervening when the illness is less acute, more moderate. And so that's something that I know we're trying to sort out in the deliberations over this bill and other proposals that have come forward. It occurred to me that a lot of the debate over what kind of information can be made available to parents, for example, or family members of people that are suffering from mental illness occurs because those suffering are of adult age, and that's when these protections kick in, which to my mind just emphasizes the importance of earlier intervention, because presumably earlier intervention at first instance, as Patrick indicated, would oftentimes be intervention that occurs before the individual reaches the age of majority and these protections kick in. So if we could promote more of that, we're not going to be diffusing all the situations where we have these kind of competing considerations between privacy and delivering care, but we will be addressing a significant number of them. and also presumably just promoting a broader and more open and more candid conversation among all the affected people in the equation, so that you begin to build a relationship and a communication, a conversation that can help support that individual as they move forward, one that includes family members and includes caregivers and so forth. And finally, early intervention, I presume, has to promote parity, and we talk about sort of legal parity and health insurance coverage parity. But the greatest challenge we face, obviously, is achieving parity in the judgment that society delivers upon one kind of illness versus another. And I think that we all want to get to a place where our reflexive response to someone who is suffering from mental illness is on par with the way we respond to those who are experiencing a physical trauma, kind of in the traditional sense. I'm committed to this ongoing conversation. I thank Representative Murphy for putting this in front of us for discussion. I thank Representative Matsui for her important contribution to the conversation. It's something we have to continue going forward, and I don't really have any questions, just to thank you all for your testimony today, and I'll yield back.
Chair thanks the gentleman. Now recognize the gentleman from New York, Mr. Collins, 5 minutes for question.
Thank you, Mr. Chairman. Before I get started, I just need to go out of my way to thank Congressman Murphy for his tireless work on the important issue we're here talking about. As a co-sponsor of this bill last Congress, I am pleased to see this moving forward. This is certainly one step in that process. But I want to particularly thank Congressman Murphy for adding into this bill, Section 207D, a version of the Ensuring Children's Access to Specialty Care Act, which I introduced earlier this year with Congressman Joe Courtney. This provision adds child and adolescent psychiatrists to the loan repayment program in the National Health Service Corp., or NHSC, for those doctors who practice in underserved areas. I believe this is an important step forward in getting mental health treatment to children, and I will continue to work to ensure that all pediatric subspecialties are covered in the NHSC program. I think we've covered a lot of the details today, and but I did hear Mr. Rosenthal, you mentioned, and I know you're a supporter of Obamacare, and we can all agree to disagree on certain things. You certainly left it hang out there that because of Obamacare in the Medicaid expansion, in those states that have accepted Medicaid expansion, they're offering significantly better, different programs in mental health than the states that did not accept expansion. And I guess in the category of you don't know what you don't know, it's been my impression that with one minor exception, which is an optional minor demonstration program dealing with reimbursement for emergency inpatient psychiatric care. With the exception of that, the main thing that the Medicaid expansion did was change the income guidelines under which patients would qualify for Medicaid. States that accepted the expansion were able to get people in at a higher income level than states that didn't. But I wasn't aware that there was this wide area of different programming, et cetera, going on. So I guess all I can do is say I kind of take issue with that piece of it, which is kind of hung out there. But also I just want to bring up, we had under Chairman Murphy, a hearing on SAMHSA. And in that, clearly, this committee was generally not happy with some of the outcomes, the expenditures of money, and so forth. And I know, correct me if I'm wrong, but I think the majority of your funding comes from SAMHSA, so yours doesn't. But I'm assuming you're well versed in what SAMHSA does.
I would say 3% of my funding.
Okay. But I know you do deal with SAMHSA and get...
Yes.
Okay. So I guess kind of as a pickup on that particular hearing, I believe this committee would like more local control of dollars, good reporting coming back, because, you know, SAMHSA is a funding mechanism to get grants out. I mean, could you share with us here your thoughts on SAMHSA and how we might have the taxpayer dollars go to better use with that funneling mechanism? Have you got any recommendations? I don't know that it belongs in this bill or not, but would just be interested in your observations there.
Well, as I said earlier, I think SAMHSA really helped birth the recovery consumer movement, and my experience with them and the contracts that I'm working on is really focused on peer support, healthcare integration, employment, things that are, you know, non-controversial and very important and significant. I think that arguments have been made that SAMHSA needs to be more balanced, but I think that the solution of eliminating it is not the way to go. We will lose an important resource in decades.
Yeah, I don't think that's been suggested, but like some government agencies, I think at some point more accountability, more metrics.
I don't disagree with that, Congressman. I think
Okay.
SAMHSA needs more accountability.
Yeah. Well, I appreciate all of your. Oh, you'd like to make a comment?
Yeah, I mean,
We only got about 30 seconds. But.
SAMHSA's budget is $3.6 billion. The NIMH's budget is $1.2 billion. SAMHSA's efforts to try and provide and innovate mental health care from the perspective of the academic psychiatric community has been a disaster. They have not had a psychiatrist in a significant position of leadership in that in a decade. There's an ideological bias which pervades the organization. In fact, I would go so far as to say that SAMHSA is a proxy agency for the anti-medical, anti-psychiatry approach to mental health care.
I can appreciate those comments, and certainly we continue to look to Chairman Murphy to lead our discussion in many of these areas based on his expertise. And while I don't think anyone would suggest SAMHSA go out of existence, I think we want to see our taxpayer dollars go where they should, and perhaps a rebalancing might be appropriate as we move forward, and would certainly appreciate your input on that. My time's expired, Mr. Chairman. I yield back.
Chair, thanks to gentlemen. I don't see any other Health Subcommittee members present, so without objection, we'll go to, do we have full committee? Full committee members. Mr. Tonko, you're recognized 5 minutes for questions.
Thank you, Mr. Chair. I think we need to identify for the record whether or not we eliminate the SAMHSA role with the creation of a new structure within the Secretary's position.
Do you want to respond, Dr. Murphy?
What we do is we elevate SAMHSA from an agency to having an Assistant Secretary of Mental Health and Substance Use be the head of that. And so it's not eliminated at all. It's elevated in terms of the authority of that. As you know, with these 112 federal agencies out there, someone needs to have enough strength behind their name and title to actually coordinate many aspects of this.
Okay, I think it certainly warrants further discussion, and Mr. Butterfield, Representative Butterfield, had to leave. He's asked that that I request that this article, fatal police shootings in 2015 approaching 400 nationwide,
without objection,
be submitted to the record. And I thank you, Mr. Chair, and thank you as well to my colleagues. Certainly Representative Murphy and Representative Matsui have been doing great work to introduce legislation that continues the conversation on how we can best address the needs of those struggling with mental illness. While I continue to have a number of concerns with the Helping Families and Mental Health Crisis Act, I believe that it is a thoughtful and earnest endeavor, and it's my hope that we can all come together to move forward, address these concerns, strengthen the legislation, and produce a final product. I think it's very important that we do that, and that need has been expressed by several on the panel here this morning. That being said, Mr. Gianfrido, in your testimony, you touched upon the issue of funding for the new programs included in this legislation, stating that it is emphatically the position of Mental Health America that any offsets should not come from existing community mental health programs. One of my concerns with this legislation as it currently is written is that it's ambiguous on the funding mechanisms of many of these programs, And where it does speak to funding specific programs, it often reauthorizes them at lower levels than currently funded. As the authorizing committee, it is our job to ensure that we put our money where our mouth indeed is and provide clear and unambiguous funding instructions to the Appropriations Committee so that together we can make the strong bipartisan case that more funding is needed for mental health and substance use programs. And can you please comment on this and more generally the need for this legislation to support, not supplant, existing funding for mental health and substance use programs?
Yes, I'd be happy to. The first thing is that I would certainly encourage the committee to not make any doubt about the fact or have any doubt about the fact that those dollars ought to come from someplace else. And of course, I said in my testimony, I think they ought to come from the jails and the prisons. I think that's the place to get them from because that's the place they've been sent to. Too many dollars have been cut. You know, the state's cut $4.6 billion from mental health agencies between 2009 and 2013. And here we hear that we only put the federal level $1.2 billion into NIMH, and in SAMHSA we only put $1.2 billion into the mental health side. That's half of what the states have cut is the total federal amount. So we can't continue to live with that. If the states aren't going to do their jobs, and they haven't been doing their jobs in this area, they just haven't, federal government's got to step in and figure out how to give them the guidance to make sure that they invest this way and make sure they continue to invest early on in the process.
Thank you very much. And can I ask our other panelists to comment on that same question about supporting, not supplanting existing funding? Senator Dietz?
You know, I don't claim any expertise. I know about the Virginia system, but from my perspective, the system overall is not working. I don't think it hurts anything to examine the way you spend money and see if you can spend it more efficiently. I've never been I've been in the state legislature 24 years. I've never believed that you solve problems just by throwing money at them. But it's clear to me that in some cases more funding is needed. But we've got to make sure we're spending money as efficiently as we can right now, and I don't think we are.
Okay. Congressman Kennedy, great to see you. Thank you for your hard work.
Well, thank you, Representative Taka. You, in New York, passed the parity in New York. We acknowledge that. I would say that we can't, you know, we have to see the forest for the trees. And the forest says that if we employ a whole new financial incentive system, instead of the emergency rooms, instead of the jails, we could give better care to people, and it'll cost us less money. And talk about a bipartisan plan that would get through Congress. So we need to talk about, with GAO and OMB, new mechanisms to think about mental health in a systemic way so that we're not trimming along the edges. Because right now, Representative Murphy's statement that we're fiddling while Rome burns is true. We need to look at the more fundamental issues of where the funding is coming overall and align them in between committees of jurisdiction, because a lot of people hear about the housing issues which need to be supported, the Department of Labor issues and job training and support. None of that's aligned in our budgets, and that's what hobbles our ability to have a comprehensive solution to this challenge.
Thank you very much. Dr. Lieberman.
I completely agree. I think it's not a matter of sort of reducing funding. It's a matter of sort of I think SAMHSA needs to be basically rehabilitated, and there's a mechanism in this bill which really elevates the stature and importance of mental health care, which had been under the rubric of SAMHSA. I mean, I remember my career goes back to when there was ADAMHA, which was the combination of the NIMH and what is now SAMHSA. And there was effective oversight and direction then, but for a variety of reasons I don't claim to be privy to, they were separated. The NIMH went back into the NIH, and SAMHSA went off on its own, and it's been a complete waste ever since.
The gentleman's time's expired. Chair now recognizes Mr. Loebsack, 5 minutes for questions.
Thank you, Mr. Chair and Ranking Member. Thank you for letting me kind of be an interloper here today. Not a member of this subcommittee, and so it's a great opportunity for me to speak to some of these issues and ask a couple of questions. First thing I should say, as so many of the folks in this body, I have personal experience with this issue. My mom, as I was growing up, and as long as I can remember, as long as she lived, she struggled with mental illness. That leads me to the issue of stigma. And I'm really glad that Ms. Schakowsky talked about that. I know that you folks are very aware of that. And Congressman Kennedy, I mean, we talked about this while you were here, and you've been such a great champion on these issues. When I was on the Education and Labor Committee, we had a lengthy hearing. We had Rosalind Carter come in and talk about this. I tell people often that as a member of Congress, if I don't succeed at anything else on the mental illness front, I am going to be very successful in talking about this issue and doing everything I can to remove the stigma from this issue and those folks who are struggling with this issue. And if that's all I succeed, then I'll have at least done something while I'm here. On the policy front, I do thank my friend Congressman Murphy for his attempts to do what he can on this front. I know we can do better. He knows we can do better. And I've talked to him at great length about how we can hopefully work together to resolve some of these issues. My big issue today that I would just want to mention briefly has to do with children, has to do with rural areas. And there are a number of us on this panel who are from rural areas. Clearly, children are best served by providers that are trained to meet their needs. There's no question about that. That may mean a child psychiatrist where one is available, and that's the big issue in many ways. But it should also involve pediatricians, I would argue, that have well-established relationships with families and that serve as a medical home for children. But in Iowa, there are only 53 child and adolescent psychiatrists. Now, we only have 3 million people, but only 53. And these providers are concentrated in 14 counties. That leaves 85 more rural counties without a single provider. Also, the provider on average is 52 years old, so the demographics are there as well. You know this very well, Dr. Lieberman. I'm going to be introducing legislation soon that would tackle this issue by supporting innovative programs that operate in more than half of all states, including my own Iowa, to provide mental health consultation by child psychiatrists to pediatric primary care practices, often called child psychiatry access programs, to enable the pediatrician to treat a child in his or her office or refer to a specialist if that's necessary. These programs, I think, show a lot of promise. They're being well received by pediatricians and by child psychiatrists alike. So I guess I'd like to, Dr. or Mr. Gianfrido and perhaps Dr. Lieberman as well, and anyone else, talk to me about these issues, if you would, about the need for early childhood intervention and treatment programs, and about how the needs of children are different than the needs of adults, and how child psychiatrists are uniquely qualified, if you will, to help this population, then integrating that as well, as I've suggested.
Well, you know, starting from a non-clinical perspective and mostly sort of a parental perspective about this.
That's important.
It was absolutely essential that my son at a relatively early age had access to a good child psychiatrist. He had access to a good child psychologist as well, and they together really helped develop a plan. Now, it didn't work out all that well because we couldn't integrate what the schools were doing, and that's a whole other issue we all need to talk about, how we do that with kids. But it is absolutely essential that we get those perspectives working with parents and the parents' pediatricians, as you point out, that right from the start, because together, all of those four parties, if you will, and the social workers who assist and others too, can put together the kind of plans that can change trajectories of lives. And that's what we have to think about here. We don't just have these two populations. All these people are going to get better on their own, or those other people we have to wait till disaster occurs to treat. 99.9% of the people are like my son, somewhere in the vast middle of this. And we can do so much for them if we all work together, just like you're going to do so much for us by all working together this year.
That's right. Hey, we've done some of that on this committee already, and I think we've already set some good examples. Yeah, Dr. Lieberman.
I couldn't agree with you more. I mean, if you talk to any primary care doctor, whether it's a pediatrician, a family medicine doctor, or an internist, they'll tell you that 40% of their practice or more is psychiatric. And there aren't enough child psychiatrists, there aren't enough adult psychiatrists to go around, and we need to have really teams of mental health care providers, which include all the disciplines, psychology, social work, nurse practitioners, that are, you know, have defined roles and responsibilities. But the frontier, or the line of first defense needs to be in the primary care system. And so mental health education needs to be part of all the primary care system. That includes pediatrics, OBGYN, and family medicine.
Just add, collaborative care models have been validated through 80-plus randomized control trials. So this notion of building this has been demonstrated to be cost-effective in outcomes, and why we don't have insurance companies reimbursing for something that's in their self-interest in terms of better financial interest and better health, something we still have to work on. But you're right on target with this, trying to bridge this gap in the workforce shortage by having more collaborative care models.
Thanks to all of you, and thank you, Mr. Chair. Thank you.
Chair, thanks, gentlemen. Now I recognize the gentleman from Indiana, Dr. Bouchon, 5 minutes for questions.
Mr. Chairman, I yield my time to Mr. Murphy from Pennsylvania.
I thank the gentleman from Indiana, and just a couple quick questions here. Dr. Lieberman, is there anything we can do to really totally prevent schizophrenia and bipolar right now?
I think that these conditions are preventable in the sense that we can't cure them, but we can stop them from starting. The way to do that is really already been, a template's been created in the area of cardiovascular disease. In 1955, President Eisenhower had a heart attack. And, you know, I think it's known that he loved to play golf. He was a chain smoker. He was obviously in high stress. He had a heart attack. And he went in the hospital for 4 weeks. He rested. Afterwards, they told him take it easy for another 4 or 6 weeks and then come back to work. And he sort of resumed his same lifestyle. And some years later, from a recurrent heart attack, he died. But that stimulated public attention and galvanized research in the medical community and the NIH funding. And 50 years later, the morbidity and mortality of cardiovascular, arteriosclerotic heart disease is 60% less, 60% less. But apart from that, it transformed the way cardiovascular disease was managed. It's no longer wait till somebody gets sick and then put them in the hospital or treat them with something. It's when you're born, you know what risk factors you have. You may have a family history. As you grow, you have to watch your weight. Your family may want you to watch your diet. You can have your cholesterol measured. There's now gene panels which assess risk for cardiovascular disease. So preemptively, these are being addressed. But if you do get into a point where you're short of breath and you have chest pain or something, you can have a thallium scan, you can have a stress EKG, you can have various tests with premorbidly, that's your secondary prevention.
Are we getting to some of those? So one
so-
comment
so-
Mr. Rosenthal said, by fostering a sharp swing to a more medical biological approach to mental health is we shouldn't be doing that necessarily, but yet last summer they identified 108 genomic markers of schizophrenia. I see that as a breakthrough. I hope we can get there to do these things. And let me give a couple concluding comments. I think I'm the last person to question here. Senator, I feel like I've met a new friend today, and I thank you for that. I thank you for your courage and your tenacity as well. If every state had someone like you, if our nation had more people like you, we'd get this done. Patrick, also a dear friend, thank you for your voice on these issues. It's powerful. We have to keep that up, keep them motivated. Jeff Lieberman, I know you dedicate these things. You're a great voice in saying we can solve these problems, and we'll do that. Paul, we've developed a good friendship over this too, and understand we have common grounds here. We have got to work in these prevention issues. It's your work that made substantial change in this bill. I thank you for that. We'll keep working on that. Mr. Coe, Ms. Billingsley, and Mr. Rosenthal, as I said earlier, there's a lot you said I totally agree with, and what we have to do is find the right wording to make sure we have that in there. You've heard a joint commitment here as we go through with Ms. Matsui, Mr. Tonko, and others here. We have more conversations of this on the floor than, of course, the media would never report, but you know what? We're actually working together, and maybe that's the news. But in this, because we've been so involved in mental health for a long time, I began some 40 years ago at this too. But I think about when we're all fresh and wet behind the ears and dealing with the mental health field, one of the things that oftentimes struck me is, why do we do it this way? Why can't we just help these families? Why can't we just talk to people? Why can't we use evidence-based care? And oftentimes we were told, well, we can't do it that way because, and it shouldn't be that way. I say psychiatry and psychology are the only areas of medicine that are defined by lawyers. And we need to make them defined by the patient's needs, by the consumer's needs, and get involved in a model that says, really, yes, we can. And not only yes, we can, but we have to. Now, with regard to funding on these things, look, I'm first in line to nag the Appropriations Committee. And I know the Senate may have some different rules they can follow, but we've got to put a bill through that is budget neutral, We are working hard to find some offsets on this. I look forward to working with my colleagues on this. I have no doubt that there's equal passion for changing these things, and we'll do these things together. And I ask along those lines that all the members of this panel, all the witnesses, all the members of this subcommittee and others, we'll keep working together. You've given us some great ideas today about what we have to do about the wording for this. But for all those people who we've lost this year and lost in other years, let's not make their lives a lost cause. Let's join together and recognize that we have to make sure that those disappearance of their lives shouldn't be a disappearance of our passion and our dedication to this. We can make this happen. I fear greatly for this nation if we do not make this the year that we make these significant and substantial reforms in this. Let's use our voices together. We will not be silent. We will make some changes here. And with that, Mr. Chairman, I thank you for your leadership in this as well. We can get this done. Hopefully next time we get together, it'll be for markup or as a group. But with my colleagues, we'll work together on some wording of these things for their concerns. And with that, I yield back.
Chair, thanks, Dr. Murphy. Thank you for that excellent summary of our hearing today. And Chair, I'd like to thank all of the witnesses for your patience, for your testimony, your expertise. This has been a very important hearing in this whole path that we're traveling on this issue. And the committee will act on this legislation. Members who are not here will have questions. I'm sure some of us may have follow-up questions. We'll submit those to you in writing. We ask that you please respond promptly. I remind members that they have 10 business days to submit questions for the record. That means they should submit their questions by the close of business on Tuesday, June 30th. Without objection, the subcommittee is adjourned.